5, 4, 3, 2, 1, and we are live.
Hello there. Good evening, everyone, and welcome to the 4th annual Indo-US Hand Surgery Conference. As many of you are aware, this is session number 3 out of 5, which is being held on every Saturday in May at the same time, 8 p.m. Indian Standard Time. This is a virtual session because of the pandemic, and as you know, that the theme this year is common conditions in upper limb surgery, how I do it. Today's session is going to be superbly managed by Binu Thomas from CMC Vellore, and he's got a wonderful cast of faculty, including Sabapathy from Coimbatore, Amit Gupta from Louisville, Paul Binhammer from Toronto, as well as Shrikant Chinchalkar from Toronto, Sam Pallapati from CMC, and Shailesh Gupta from Indore. None of this would be possible without our sponsors, and they have given us great support. The Weiss Medical Foundation, the Deshpande Foundation, Venus Safety and Health, and finally, the Indian Society for Surgery of the Hand. Without OrthoTV, this would not be possible either. So Ashok and Sham, we are very grateful for your support. We will be asking you to participate very robustly and ask a lot of questions. For that, you have to scroll down to the link, which is below the link on OrthoTV. And your questions will be automatically sent to us via the link or via WhatsApp to Dr. Bhatt. With that being said, I'm going to hand it off to Binu Thomas. Binu, all yours, buddy.
Thank you, Chai. Good evening and greetings from Vellore to all of you. I'm very happy to moderate this session on behalf of the 4th Indo-US Hand Surgery Conference. In the early 50s, when in Louisville, Dr. Kleinert and Dr. Kutz decided that the management of flexor tendon injuries was inadequate, and they put forward their regimen for management. It opened out a new, entirely different way we manage flexor tendon injuries. And this is why today we have a session on tendon injuries and also added with fingertip injuries and other things. So without much ado, we'll start it. One thing is, most of the faculty here have been trained or as Dr. Amit Gupta, been faculty at the Christine Kleinert Institute, which is considered the Mecca of hand surgery, which was established by Dr. Harold Kleinert. So the first to start is Dr. Samuel Pallapati. He'll be talking on mallet finger and jersey fingers. Sam, I'm just going to share the screen.
Greetings from Christian Medical College, Vellore. Good morning to those of you in USA and good evening to those of you in India. My heart goes out to all those suffering with pain and anguish because of this pandemic. My thoughts and prayers are with them. I wanted to recognize two legends in hand surgery, both recognized as pioneers. One is Dr. Paul Wilson Brand, who was a Christian missionary surgeon. He started the hand surgery unit back in 1951 in our hospital. He was a doyen of tendon transfer surgeries. He worked in India, thereafter in Kenya, and then in USA as chief of reconstructive surgery. I had the immense pleasure of working with Dr. Kleinert in Louisville for 2 years. His passion for hand surgery, his dedication, his meticulous surgery and attention to detail was something to learn from. I will deal today with two kinds of injuries. One is flexor tendon injury, insertion to bone at the distal phalanx, injury causing jersey deformity. The other one is injury of the extensor tendon at its insertion to distal phalanx, causing a mallet deformity. Problems with this kind of injuries are that there is no luxury of end-to-end placement of suture. The adequacy of tendon anchorage to bone has to be ensured. Post-op mobilization, immobilization has to be carefully monitored. Any morbidity because of these procedures has to be considered. Also, the expenses the implants that are used sometimes may entail. Lady and Packer had given this very useful classification. Type 1 FDP avulsion is where the avulsed end of the tendon lies in the palm. Type 2, the tendon end lies in the middle of the finger, distal to the A3 pulley with a small fragment. Type 3 is where there's a large distal fragment. It's usually distal to the A4 pulley. How do you diagnose a jersey finger? It is a closed injury. Patient may sometimes report a pop. There's inability to flex at the DIP joint. X-ray and ultrasound scan are usually confirmative to identify the lesion and the location of the lesion. Operation is indicated to correct the lesion. This is a patient who presented delayed with inability to flex the DIP joint. It's interesting to note that jersey finger more often involves the ring finger. It's possibly because as we flex the fingers, the ring finger stands tallest. I'll run through the operative procedure quickly. Brunner incisions are used. The A4 and A2 pulleys are identified like so. Thereafter, the incision in the palm identifies the FDS tendon. You can gently tug at the FDS tendon proximal to the A1 pulley and ensure normal flexion of the PIP joint. You identify the FDP tendon very easily because of its association to the lumbrical muscle. There is scar tissue around the tendon and this has to be cleared carefully. After the scar tissue is cleared, we have to make sure the tendon and glides freely through its amplitude as shown here. In the finger, we have to open the A3 pulley to identify the two slips of the PS tendon and then identify also the chiasma. Since this is the delayed procedure, the A4 pulley may be collapsed. This can be gently dilated using increasing diameters of a feeding tube as shown here. The pathway of the FDP tendon is clear of all scar tissue and smooth passage of a freer elevator can ensure that the pathway is clear. A feeding tube drain can then be threaded from distal to the A4 pulley through the A4 pulley, A2 pulley, and the A1 pulley so as to exit in the palm. This is the technique used in case of delayed presentation where you need to put a tendon graft. If it's an acute presentation, you might be able to get away without use of a graft, but the concept is the same. Palmaris longus tendon can be harvested easily using two small incisions like that. The graft is then sutured to the end of the feeding tube and very carefully threaded through the pulley system to the region of the distal joint. 4-0-proline can be used to anchor the tendon graft to the bone. Bunnell suture may be placed carefully to get enough bite. Different techniques have been described to get bone anchorage of the graft or the tendon. You can drill through the bone, or as seen in this picture, which I prefer, we can skirt through the either sides of the distal phalanx to exit on the dorsum of the nail plate. And this is then sutured over a button. The button is placed with felt padding on either sides of it so that you minimize the pressure effects. Additional anchorage sutures can be placed to the local tissue near the insertion of the tendon graft to increase the hold on the distal phalanx. It's important to close the finger sutures before going on into the palmar surgery. You can also very carefully pull on the tendon graft to ensure adequacy of the bony anchorage as well as the pulley system. After proximal suturing of the graft to the cut end of the tendon, we can ensure the normal cascade of the fingers has been restored. We use a modified liner traction for 4 to 6 weeks. Thereafter, gentle mobilization and prehensile activities are started. The problems can be the technique, which can be challenging. Nail deformities, we have not had much problems. Sometimes retained sutures can cause a problem. Alternatives can be used of a steel wire for suture. Bone anchors have been described. They're very good because they give you good anchorage into the bone and there's no question of suture removal from the tendon. In case of a fracture avulsion, as shown here in Lady Packer type 3, you'll have a fracture to handle. This is a picture provided by my colleague. Exploration of the finger revealed FFTP avulsion with a bony fragment. Reattachment was done using a mini small fragment plate as shown here. It's very cute. This is an early follow picture. Fracture is united. The patient has started showing reasonable finger flexion. Okay, going on to mallet finger deformity. It's usually caused by ball games. Cricket is very common cause for such deformities in India. Nursing profession They can have this problem while tucking a bed. Mechanics can have some accident can cause a deformity, but there's a finger drop at the distal interphalangeal joint. Doyle classified it into type 1, 2, 3, and 4. Type 1 is a closed injury. Type 2 is a laceration. Type 3 is a laceration with soft tissue deficit. Type 4 involves a fracture. In closed injuries without any major bone fragment, conservative management using a stack splint can be applied. We use usually custom-made splints like this. This is a leather wire splint, which has a very good 3-point grip on the distal joint. We can also use a thermoplastic splint like so. The patient is asked to comply for 6 weeks of continuous use, thereafter 2 weeks of nighttime usage. They only take it off for cleaning the finger, but they have to make sure the DIP joint is maintained in extension during the cleaning time. When there's a history of laceration, this picture belongs to Dr. Joseph Kutz. We need to explore, repair the tendon, thereafter transfix the joint using a fine caver in neutral or mild hyperextension position for a period of 6 weeks. When there is a mallet fracture, surgery is indicated. Usually, different techniques have been described to reinsert the bony fragment back into the remainder of the distal phalanx. Pull-out suture, KYs can be used. The joint is transfixed again in neutral or mild hyperextension. Some of my colleagues like this procedure described by Ishiguro 1988 for mallet fractures. There's a KY that is used to joystick the fracture fragment into a proper position. The KY is then run into the head of the middle phalanx. The rest of the distal phalanx is then reduced onto the fracture fragment, and this is held in position using a KY, which also transfixes the joint. These are intraoperative pictures, preoperative, intraoperative, and postoperative. You can see that the fragment is reduced and the joint is held in mild hyperextension. This is a postoperative picture showing good union. It's actually anatomical. And the KYs are removed at 6 weeks after ensuring fracture union. During the postoperative period before KY removal, the finger can have a cast. After KY removal, gentle, active, and passive hand therapy is instituted. Stack splint may have to be used for a period of 4 weeks further. To conclude, jersey and mallet fingers, both of them need custom-made care for each patient. Surgery warrants meticulous handling. Careful post-operative immobilization, mobilization has to be done. Thank you and God bless. Greetings from Christian Medical College. Good morning to those of you in USA. Good evening to those of
Thank you very much, Sam.
Pain and anguish because of this pandemic.
While we are waiting for the questions, we will have Dr. Mr. Mahesh from Venus Surgicals just coming in while we are waiting for questions.
Mahesh, can you unmute yourself?
Yeah. Well, good morning, doctors in US, and good evening, doctors in India. I'm Mahesh Kodau from Venus Safety and Health. And in the last 18 months that I've been working closely with various doctors, my respect for your profession has still grown many times more. I've been meeting various doctors and surgeons and trying to solve the respiratory products. Thank you for everything that you guys are doing for humanity and mankind. Thank you, Chaitanya.
All right. Thanks, Mahesh. Mahesh, thank you for joining us and thank you for supporting our venture. We appreciate it a lot. We would not be here without our sponsors, and Venus Safety and Health have been a big sponsor of this event. So thanks to Sushi and you. I understand that you are very busy in this pandemic. So if you have stuff to do in this evening, please go ahead and do what needs to be done. And we really appreciate your support. I'll talk to you later, okay?
Sure. Thank you very much.
Thank you very much. Binu, all yours, man.
Thank you, Mahesh. Sam, get ready for the questions. Anil, do you have any now?
Right now, nothing.
Can they show me on video, please? can somebody show me on the video?
No. We'll ask you a question, Sam.
Okay.
Okay, so we were waiting for anything on WhatsApp, but Anil said right now it's probably too early days. So let me ask you one question.
Yeah.
What about mallet finger in children? Have you come across them, and is there anything different to manage?
Exactly, not because of games or sporting injuries, but children, they have this door crush injuries. They put their fingers at the door while closing, and they can have usually an open injury. And here we have to be very careful about an epiphyseal injury, which could have separated, but there could also be a Seymour lesion where the nail plate and the nail bed have jumped over the nail fold and standing on top of the nail fold. So this has to be carefully handled. Not only should the fracture be fixed with a fine caver, but the nail plate and the nail bed have to be restored back into their position to be seated deep to the nail fold and to be sutured carefully. So that's what we should be careful. A Seymour lesion that could be hiding an epiphyseal injury with an extensor apparatus injury. Yeah.
Hey, Sam, in the Indian subcontinent, do you see the variation of the bony avulsion where the fragment avulsus sits at A3 and then the tendon avulsus from the fragment and goes down to A1?
No, I have not really seen that kind of fracture, but there's a newer classification that adds type 4 and type 5, where type 4 is a large bony fragment avulsed, but the tendon itself is separated lying in the palm. That's been described. And type 5 is where there's a fracture avulsion from the distal phalanx, but the distal phalanx itself is again fractured, separate fracture. So type 5. So I guess that can be pretty challenging to handle. But yeah, depending on the size of the fragment, I would decide whether to put a graft and put it back into the distal phalanx, or whether the fracture fragment has to be fixed to restore that anatomical congruity of the joint.
Anil has a question.
Yeah, Sam. For the jersey finger, often the repair site lies under A4 pulley. So how much should we release the pulley if at all? And how do you deliver the proximal tendon under A4 pulley? Is it necessary? How do you check the glide if it's so?
I wouldn't really, the problem with jersey finger is, I have had problems. The tendon is not coming freely into the distal phalanx region. I wouldn't hesitate to put a graft. If you put it slightly tight also, there's a possibility of quadriga effect, and then the flexion contraction that can be very tight and difficult to overcome. So if it's slightly delayed presentation and the tendon is slightly proximal, I wouldn't hesitate to jump a graft. But to deliver a FTP tendon in an acute case, I prefer actually straightening out the neighboring fingers, and that stretches the FDP tendon of that finger where there's injury, and it's easily pulled with using a hemostat. So I usually make use of the quadriga effect to deliver it, or you can again use an infant feeding tube drain, as like I showed you in the picture in the video. You can thread a feeding tube drain, suture the graft, and then suture to the tendon, pull it to the distal insertion, and hold it there with a hypodermic needle so that you can do your surgery at the joint.
Chai, if I may ask, Chai, what would you do in the situation that you just described, that the bone fragment is at A3 and the tendon is separate? So what would be your choice of management?
So I came upon that by happenstance because I had a case, I think, and we published that a while ago. And I put the bone back, focusing on the bone. And I take a Bunnell pullout with 2-O-Proline. And the bone is fixed to the parent bone with small fragment, mini fragment screws, 1.1. Then I take the Bunnell pullout and drill holes with 2 straight Keith needles, which emerge past the lunula on the nail plate. And that's critical, otherwise they get a dystrophic nail, as we know. So those then go and they form a secondary form of holding the fragment back in place. Just should your screw fail, you at least have this pull out. So it's a belt and suspenders thing. And I take the stitch out at 6 weeks, but I start rehabbing them right away.
Right. Thanks.
So these patients usually come pretty late. Sometimes they end up in your office about 3 to 4 weeks delayed. And so therefore it's hard to pull the tendon all the way to its insertion. And then you end up with a tight finger. So what I've done is instead of going for a graft, I've put the tendon back to its original place and then done a fractional lengthening. You can do the Laviette technique, where you do a little small fractional lengthening. You can do 2 or 3 fractional lengthenings actually. And that works very well. It's a very good technique described by Laviette.
Yeah.
Gupta, do you have, at times you may have to do a DIP fusion. Do you do that, or is there?
No, I tried to avoid DIP fusion if you can. And these are athletes, and they're usually holding athletes. So you would try to avoid a DIP fusion if you can.
Even in very late cases.
In very late cases, you would try to do a graft. But in the 3 to 4 weeks, 4 weeks plus 6 weeks period, you can get away with the fractional lengthening situation.
So do you do the fractional lengthening in the forearm, Dr. Gupta?
Yes. At the muscular tendons junction, slightly distal to it.
Okay, I think we have run out of time for this.
You know, there's one question on Mallet. Late cases, are there any indications for a tendon graft? If so, what's the source, and any tricks and tips for using that? Because generally, a palmaris longus, generally there is an extensor lag seen most of the time. So, from the panel.
Yeah, there's a spiral oblique retinacular ligament reconstruction technique described, which is very elaborate. Most of the times, patients, when they come delayed, they already have got used to the finger and then having a painless functional hand. But I've found it useful to go there, and whatever tendinous substance is still there, it's usually stretched out, or the DIP joint. I transfix the joint in neutral or mild hyperextension and sort of double breast the scar tissue, whatever tendinous attachment is there still to bone, and keep it there for 6 weeks. I find it helpful. It was not a big problem. I really have not done a SO oral technique on any patient as yet. I don't know what Dr. Gupta and others will say about that.
Thank you, Sam. I think we will. Yeah, okay, Dr.
Gupta. My philosophy has been to avoid opening any mallet fingers.
So just transfix it?
Just put a pin in it, and and leave it for 10 weeks, and put the pin down below the skin.
Okay.
Okay, thank you.
When you repair it when you repair a delayed mallet or even an acute closed mallet surgically, unless there's subluxation, I remain unconvinced that the results are superior to what nature gives us. And I think nature does a remarkable job. Like you said, Sam, it's a painless finger which they get used to.
Functional.
We can pat ourselves on the back saying it looks nice, but then the patient says it doesn't bend.
Yeah, correct.
Okay. Shall we move on to the next talk? Thank you very much, Sam.
Yeah.
The next talk is by Dr. Amit Gupta from Louisville. He's one of the doyens of hand surgery, and he has been a mentor to many of us from India when he was in Kleinert Institute. And Dr. Gupta on Zone 2 flexor tendon injuries. Neeraj, you will have to share the screen on this one.
Good evening. I will share my thoughts about flexor tendon injuries and the repair and rehabilitation today. So we'll call this the scientific basis of flexor tendon rehabilitation. What is flexor tendon rehabilitation? It is basically control of the tendon healing. In order to understand the control of the tendon healing, we have to understand the factors influencing tendon healing. This could be divided into extrinsic and intrinsic factors. The extrinsic factors which influence tendon healing are the type of injury, the patient compliance, surgical technique that the surgeon uses, and the rehab program. So here's a flexor tendon injury which has been repaired under a WALANT, delayed primary repair of FTP5 at 40th day after injury. And as you can see, the flexor tendon has been repaired with a 4-strand suture with epitenon suture in zone 2. and there is full active flexion. There's no gapping, and the A4 pulley has been vented. And here's the patient at 4th month postoperative with excellent results. Now, how do you achieve that? The other influences of the tendon healing are biological and biomechanical. The biological processes which are involved are tendon nutrition, the actual healing of the tendon, tendon remodeling, and morphology of the tendon. Tendon nutrition. We well know that there are 3 types. There's the segmental vascular supply, which comes from the dorsal side. There's a diffusion from the synovial fluid, which is most important for the palmar side. And there is the synovial pump. Let's talk about this. If you look at the flexor tendon, there are lots of vessels coming from the dorsal side, mostly from the arch here proximally, and from the common digital vessels, and from the connection between the common digital vessels. And these vessels are coming from the Edwards arcade, which are connecting the 2 digital arteries and going through the vinculae longae and vinculae brevae to supply the flexor tendon on the dorsal surface. And here's the dissection of these vessels, and here's the vinculae longa and vinculae brevae. And these vessels come and run longitudinally on the dorsal surface of the tendon, so we tend to put the sutures on the palmar surface. However, the tendon is also nourished by the synovial fluid, and Luger and Lundberg put these tendon repairs in knees of rabbits without any vascular supply, and the tendon still healed because it could get nourishment from the synovial fluid. Now, if you look at the tendon collagen, it's longitudinal, and the collagen on the undersurface of the pulley is transverse. Together, they form a lattice work, and as the tendon moves back and forth, it traps the fluid, synovial fluid, and pushes it into the tendon, thus creating the so-called synovial pump. Well, how does the tendon heal? The tendon heals by intrinsic healing. That is, there are tenocytes, just like primary bone healing. And this process was popularized by Mathew and Richards, Lundberg, Manske and Gelberman, among many others. In the 60s, it was very popular to talk about extrinsic healing, popularized by Potenza and Peacock. There's proliferation of extrinsic fibroblasts from tendon sheath. Like everything else in life, there's a combined process of healing. Union is first affected by the proliferation of the sheath cells, followed by the tendon cells. So first external healing, then intrinsic healing. How does the tendon remodel? We know that early motion results in fewer adhesions, smoother gliding surface, as shown by Dr. Gelberman, and it stimulates intrinsic healing and remodeling process. If you look at the scanning electron microscopy of the tendon which has been immobilized, you see very rough areas, and the same thing when the tendon has been mobilized, you see very smooth areas. So mobilization improves the ultimate range of motion, the strength, the DNA content, tendon nutrition, and the rate of healing of the tendon. What is the effect of a suture on the tendon? The suture is a necessary evil. You have to put a suture, but there is a dramatic cell depletion and cell migration from the site of the suture application in intrasynovial tendon. And this process persists for 14 days, as has been shown by McGrather. So here's a process where the cells are there in the tendon, the tenocytes, and the tendon cells, as you put the suture in, the tendon cells are depleted from the area of the suture, and the inflammatory cells are coming in. These are the neutrophils and the other inflammatory cells that are coming in, but the tendon tenocytes have gone away from this area of the tendon healing. And this persists for up to 14 days, and therefore this area is weakened, and therefore we see the weakening of the tendon. Morphology of the tendon. The force transmission of the tendon is increased by softening, swelling of the tendon, the viscoelastic force of edema, adhesion, stiff joints, and partially open pulleys, and also bulky repairs. So you need to try to reduce all of these factors. We know the tendon sheath, the pulleys, the annular pulleys, the cruciate pulleys, and how the tendon injuries can be divided into the different zones, and the zone 2 is further subdivided into different zones by Jin Bo-Tang. Here are the pulleys and the tendons shown in a dissection, and you see the entrance of the pulleys. Now, here are the things which affected the major annular pulleys, volar tissues, edema, extrinsic extensor tethering, and joint stiffness, friction, etc. Now, how to prevent this? In the old days, we used to close these pulleys, but now you can vent the pulleys. You can cut the pulleys, or in some instances, you can divide the A4 pulley completely if the tendon is catching in your pulley area, and that will allow a better gliding. So here's a tendon laceration at 2 weeks, 2 weeks ago, and you see that small finger tendon is lacerated. The tendon has been exposed, and now the tendon is being repaired. So once you have repaired the tendon, the zone for A4 pulley was vented, and so you see C1, A3, A2, C4, and C3 pulleys are vented, and you see there is a mild bow stringing. But is that clinically relevant? It's not that clinically relevant, and you can see that the patient can have very good range of motion despite the bending of those pulleys, as I mentioned. And this goes on to heal very well. So what are the biomechanical factors? They are the suture strength, the gap formation, tendon excursion, joint influences, muscle actions. Suture strength. We know that suture strength is important. And if you look at this, 2-strand suture will withstand 17.6 newtons at 0 weeks. At 1 week, the tendon repair weakens, and 3 weeks, it's still weak, about a third. And at 6 weeks, it's very strong. So this is tendon repair with a 2-strand suture. This is with epitenon suture. In parentheses, 4 strands, stronger, 6-strand, much stronger. How much do we need? We need, for passive motion, we need about 5 newtons. And for light grip, we need about 15 newtons. And for strong grip, we need about 50 newtons. And tip-to-tip pinch, we need about 88 newtons. So we use the Sai suture, the 6-strand Sai suture. It's pretty bulky, but you can bend pulleys and get this tendon to glide. Jinbo Tang uses his own 6-strand suture technique, but you can use 4-strand suture, and that's pretty adequate for most rehab processes. Gap formation, we know, is pretty bad, and it's been shown and it's been proven for many years that this is not a good thing to have. Increases lesion formation, increases tenolysis rate. Here's a zone 2 FTP 4 and FTP 5 injury, and as you can see, we'll get that. And here's the tendon injury, and the tendons have been brought in and sutured, and we'll go through this 4-strand cruciate repair. And as you can see, as the patient flexes the tendon, active flexion extension test, there is a little gap formation there. Now you can see this immediately when you're doing this, and the patient can actively flex and extend. This is not a good thing because this will increase adhesion formation and it will increase tenolysis rate. This can be strengthened with additional core sutures, as was done, and this results in no gapping now and goes on to rehab very nicely. So excursion, we need about 3 to 4 millimeters of excursion for stimulating intrinsic healing and prevent or decrease adhesions. And so we can use the wrist motion to increase the tendon excursion, and including the wrist motion, we can increase the range of motion of the tendon, and also making a fist, we can increase the range of motion of the tendon. What about joint influences? So we know that the very last degrees, final degrees, when you do active flexion, puts tremendous force on the tendon. So you should avoid the very last degrees of active mobility of the DIP flexion. So that should be avoided. And we want to get PIPs extended by 2 weeks. It's been clearly shown that stiff joints increase force on the tendon, and lack of complete PIP extension at 2 weeks is a determinant of poor function. And so we try very hard to get full active extension by 2 weeks. Increased MP flexion encourages lumbrical recruitment and encourages PIP extension. And the muscle action, we've shown that if you recruit the lumbricals, they will pull the tendon from their insertion to the extensor tendon, and therefore unload the flexor tendon repair. And you see, as you flex the MP joint, the lumbrical action is increased. And here, that's what we have done. So evolution of tendon repair has come with the understanding of flexor tendon healing. So we started from here, and in 1955, the series came out when 98 flexor tendons were repaired in no man's land. They got 1% good results and 94% failure. In the face of this, boys said that perhaps it would be well to discourage the use of the phrase primary tendon repair. In the face of this, our mentors, Dr. Kleinert and Dr. Coots, persisted with repairing flexor tendons, and they were able to show in 67 that you could repair flexor tendons, and that was a quantum leap, and in fact, put Louisville on the map. Many series have come out showing different rupture rates and results of tendon repair over the years. But the application of basic knowledge shows that tendon nutrition, we place the sutures volarly, tendon healing, we start early motion, tendon remodeling, we start early motion. So we've come from this to this to this, where we can actually free up the tendon, free up the wrist in the Manchester short splint. We still can use the Kleinert technique and combine it with active mobility and use the things that we've learned over the years. The Manchester short splint we've described. So combination of controlled dynamic, passive and active motions is important. And we can reduce gap formation by strong suture, epitenon suture, ensuring compliance, and we protect. Morphology, we reduce the viscoelastic forces by avoiding stiff joints, avoiding partially open pulleys, and bending the pulleys where necessary. Joint influences, we use the FDS and FTP differential glide, the Webby exercises, alter the wrist position, and we can get full extension of the PIP by 2 weeks, and we put in more MP flexion and avoid the final tight flexion hold. Recruit beneficial effect of the lumbricals with full flexion of the MP joints and wrist position. In the future is the molecular manipulation of healing, gene therapy, growth factor manipulation. And so flexor tendon repair and rehabilitation, respect for biology and biomechanics, application of basic knowledge has resulted in control of the healing process and successful rehabilitation. Thank you.
Thank you very much, Dr. Gupta. Thank you very much for the excellent talk. Anil, any questions?
Nothing from the audience yet. Yeah.
Okay. So, like the A4 pulley, can I ask you a question? Like the A4 pulley venting, do you also do A2? If there is
try to avoid doing A2 pulley, but I will not hesitate to cut the A2 a little bit. You can cut the A2 a little bit from the side. You can make a flap of the A2. When we are training, Dr. Lister was very insistent that you have to repair everything. All the pulleys were repaired, watertight repair, as he used to call it. And if you did a bulky repair, that would cause tremendous tightening of the tendon sheath. But they got good results because they were using two-strand sutures, the so-called Kirchmeier sutures. And Dr. Kleiner would never call it Kessler sutures. You always say Kirchmeier sutures, because Kirchmeier described it before Kessler. So Kirchmeier sutures are two-strand sutures, and they were using two-strand sutures with nice epitenon sutures, and then using the protection of the Kleiner protocol. But A4 pulley, I've cut completely. A2, I have not cut completely, but I have, divided a little bit.
What is your rupture rate nowadays with current regime? Pre-rupture rate.
Rupture rate. When we published the results in the 90s, our rupture rate at that time from the Louisville series was 0%. The rupture rate varies from 1 to 3% in all series. If you look at it, the higher side is about 4 to 6%, and the lower side is 0 to 1%.
Dr. Gupta, when you have a delayed presentation in zone 2 and you have to reconstruct the A2 pulley, what is your tissue of choice if you have to reconstruct the pulley?
I tried to take a palmaris or plantaris or extensor tendon of the toe. So fourth toe extensor you can easily get, and and you can very easily take the fourth toe extensor by making small incision over the dorsal of the foot, and then using a tendon stripper, and you can do it under local anesthesia. And so it gives you a very nice and long tendon, or you can take the plantaris. But if you are also going to need a tendon for graft, so you got to be careful which way your tendons are. If you're going to need your tendon for a graft, and you have to choose a longer tendon, then try to choose the longer tendon, the plantaris or the toe extensor for your tendon graft, and a shorter tendon like the palmaris for your tendon reconstruction, for pulley reconstruction. Or you could take the FDS, flat portion of the FDS as a pulley reconstruction technique. The way I do that is around the bone, just like Dr. Planet used to, yes, around the bone. And we've had pretty good success with that tendon reconstruction, with the pulley reconstruction.
Yeah, thank you.
Anil?
Dr. Gupta, there's one question from Dr. Ashwat. What's your philosophy on FDS repairs in the zone 2 area? When you might not do it, the FDS repair, if at all, is it necessary to do the FDS repair?
I generally have avoided FDS repair in the small finger, for sure. I don't like the small finger for any reason. Small finger doesn't give you good results in most situations. So I try to avoid doing an FDS repair in the small finger. Sometimes the FDS in the small finger is, a little less developed anyway. So FDS in the small finger I avoid. If there is multiple tendon injuries, then sometimes I'll do one single strip of the FDS repair and take the other strip out. You have to be very careful. If there is an hyperextensile joint, then you might get a swan neck type deformity or a hyperextension of the PIP joint if you don't do an FDS repair. So you can do an FDS, you can keep the tendons a little long, do a little tenodesis of the FDS at the PIP joint level if you want to avoid that. But you can create a little flexion and contraction of the PIP joint just to avoid that hyperextensile. And this happens in people who have extensile joints. Some people have lax ligaments and lax joints, and you have to be a little careful in that. But generally, nowadays, I tend to repair the FDS if it's a clean cut laceration and I'm not getting too much, bulk in there. But if there's a lot of bulk and it's getting in the way, I would not hesitate to take out one strand of the FDS.
What's your technique of FDS repair there? And would you alter the technique for any reason?
No, my FDS technique repair is just a 2-strand FDS repair with the epitenon suture. I don't do very fancy repairs. It's a very straightforward, clean repair of the FDS without too much bulk.
Do you repair both the slip or single slip of FDS?
Generally, if it's a clean cut injury and I'm not getting, it's a different, the FDS and FTP are different parts of the finger, then I'll repair both. If there's bulk, I'll repair one and I'll take out the other part.
I just want the faculty Chai, Raja, and Paul to tell us what each of them prefers to repair the FDP tendon with suture technique.
Oh,
Yeah. I normally use a 4-strand, no? Try to get a 4-strand suture. Now we're using a Ethibond 4 strands, and then the circumferential coapting sutures, and try to move them as early as possible. That's what we do.
Oh, great. Chai?
And little finger FDS, I never suture.
So, yeah, my philosophy is somewhat similar. I tend to use trio braided non-absorbable, whatever is available. I don't necessarily use a epitendinous suture, and if I don't use it, I will do a 6-strand. I'm reasonably comfortable sacrificing the FDS and putting all my eggs in the FDP basket. But if I do that, I will tell the patients that they may not have composite flexion, because as Amit has shown in his book, the FDS acts as an internal pulley on the FDP because of the Camper's chiasm. And when you take away the FDS, the FDP has an increased moment arm because it's so much freer to move back and forth inside the pulley, as a result of which its ability to flex the DIP is not as good as when you had the FDS. So I tell patients about that, and the therapist also should know that. So I use a 4-strand, occasionally 6-strand, and I'm comfortable sacrificing the FDS, depending, because one thing Amit said, which is very important, is if the FDS and FDP are cut at the same level or they are at different levels. That makes a huge difference to what I do.
Paul, what do you use in Toronto?
From a technical perspective, I do pretty much the same thing as Chai, and I might just expand a little bit on that in the sense that if I have somebody who has multiple fingers, rather than, so if you don't fix the FDS in somebody who's cut all 4 fingers, then you may be sacrificing a significant amount of muscle and power into their hands. So if you have multiple fingers, then except for the small finger, which I wouldn't fix the FDS, then I will tend to fix the FDS in the other digits so you don't lose all that muscle mass powering your finger flexors.
Great.
Binu, some questions on delayed presentations in terms of what's the indication for tendon graft? When do you decide on that? And the other one is the tenolysis. How early or how late?
Okay. So yeah. So in terms of tendon graft, so when you have done a flex tendon repair and you know, it's gone about 6 months, I usually wait for 6 months before I try to do any tenolysis. I give them enough time to, and sometimes it's pretty apparent that this is not going to work. You know, you get thick scar formation. And so in those situations, I would go for tenolysis. But remember, when you are prepared for tenolysis, be prepared to do 1-stage or 2-stage graft, because you may end up, your tendon may be ruptured and there may be significant gap. So you may have to be prepared for a few things. You may have to be prepared to do a tendon graft. You may have to be prepared to do a rod, and you have to be prepared to do pulley reconstruction. So be prepared to do all those 3 things. So when you go into surgery, if you're prepared, then you will be able to go with confidence. So start with the tenolysis. I start with the A1 pulley level, and I would open the just proximal to the A1 pulley level, free up the tendons. Then if the A1 pulley level is not successful, I'll go proceed further distally, and then free up at the A3 pulley level, going forward into the A4 and going down into the A2 pulley. And I use the Roy Mills's knives, and I think those are fairly good. And also, you know, elevators, freer elevators. Intertendinous adhesions are also very important. So you'll have if you have repaired both the FDS and the FTP, you'll sometimes find that there are adhesions between the tendons. So those have to be freed up. And most of these will be done with the patient awake, so that your patient can actively flex and extend, and you'll be able to see whether there is there's an extensive adhesion also, or you need to free up a little bit more. In terms of if there is a gap or if there is a scar tissue in the tendon sheath, and there is loss of pulleys, like say, for example, you've there is complete loss of the A4 pulley and you can't pass anything through that, then you'll be prepared to do a graft. In many instances, you may be able to do single first-stage graft with a tendon. And if you're going to repair it in the palm, and I try to repair it in the palm because I try to preserve the function of the lumbrical, in that case, a short tendon will be fine. And you can use a short tendon like a palmaris. But if you want to repair it in the forearm, then you'll need a long tendon like the plantaris or the toe extensor tendon. And as I mentioned, if I do a tendon rod, I would insert the tendon rod and I'll do a pulley repair on the tendon rod, and then come back 3 months later and replace the rod with the graft.
One another scenario would be the associated digital nerves of fractures. So the repair or mobilization protocols, do they change in any way?
Okay, so my philosophy has always been that you treat in a combined injury, you treat each individual component of the injury to the best possible level for that particular injury. So if the fracture is multiple comminuted, I would not have any hesitation of fixing that very stably. If it's not possible, if it's very crushed, I would replace it and put bone graft primarily and do a stable fixation of the bone, repair the tendons, repair the nerves, and repair the flexor tendons as best as I could at that time. Okay, so then what you can do is then you can fix and forget the bone, fix and forget the nerves, and just concentrate on your flexor tendon rehab.
When you do a tendon grafting, do you remove the lumbricals, or you always keep it?
No, I try to keep it. If that's why I put my graft. There are two ways of putting the graft in. One is that you can put the graft in the palm, or you can put the graft in the forearm. Now, if usually the flexor tendon, if it's ruptured, will have shrunk to the palm, to zone 3, where it won't go any further proximally because it's attached to the lumbricals. Now, if that is the case, then I'll try to keep the attachment of the FTP and the lumbricals intact, because the lumbricals will then function. So I keep my grafting to the palm. I'll put the graft to the palm. If the scarring is so extensive, and that you require further excision, then or if you are going in for second, third, sometimes you're going for second, third, fourth surgeries in these situations. So in that situation, I would go more proximally into the forearm. And in that case, you'll need a longer tendon. So if you need a longer tendon, you'll have to plan for a plantaris or plan for something like a toe extensor tendon. Because
Dr.
you need
Gupta?
a very long tendon. Mm-hmm.
Yeah, sometimes when the lumbrical is tight, there's something called paradoxical extension of the finger when you try to flex. So I also preserve it, but I try to slide the lumbrical and slightly weaken it a bit on the FDP tendon. So it's not actually extending the PAP joint. So but it's just about there, but not too strong.
Right. I mean, it's a theoretical consideration, but practically I've never seen it. So
yeah,
I don't know.
Binu, we have time for one question.
Yes, one more. Last one.
The last one, the preference of all of them, each of them rather, of suture material in terms of the newer ones like the double loop, Ethibond, and the classic Prolene. And
I use a trio. I use a loop suture, the Supramate loop suture. Yeah.
Chaitanya?
I just use a trio, braided, non-absorbable, whichever, Tevdek, Ethibond, whatever is available. You can't get too picky. Unlike Amit, we don't all work in rich centers.
Hey, Mass General.
Paul?
I'm like Chai. I use a braided polyester. It's a no-name suture.
SRS, sir?
Okay, I think.
Okay. Yeah. Binu, go ahead.
Unfortunately, we'll have to wind up because there are other speakers. I think we can actually discuss this for the whole day with Dr. Amit. But thank you, Dr. Amit, for this excellent talk. The next talk is by Dr. Sabapathy from Ganga Hospital. He needs no introduction. He'll take us through combined injuries. Dr. Raja.
I thank Dr. Chai and Dr. Binu for giving me this opportunity to take part in this Indo-US hand surgery symposium. My task is to speak on combined injuries. And let's first define as to what do you mean by a combined injury. A combined injury, I presume Chai meant in his mind that where there is a tissue loss at one particular site. So a combined injury means, or what you call as a composite tissue loss, is loss of multiple tissue components or injuries at same site. So there are two things involved. One is that more than one tissue, other is at the same site. As you see in this picture, skin and soft tissue are the loss, and tendons they are lost, and the bone is now shaved, and the joint is open. So this is a combined injury. So the principles are that they can be treated and we can get good results, one. And second, when you deal with them, you must make the plan not for that day, but you must make them from start to finish. 2. 3 is that if you have a dorsal combined injury, if you don't treat them well, even the flexors can't act well. If they get stiff, there'll be a loss of no flexion. And if the flexors are stuck, even the extensors are all right, that means no, you can't extend fully. And in these injuries, the key thing is you must debride well, and prevention of infection is the key to success. So when you have them, the question comes now, do you do them primarily or do them in a staged manner? The answer is both are acceptable.
I can't set a timer here. How about a reminder instead?
Only thing is that if you do in stages, it takes a lot more time, and but many people feel it's safer. I think it's according to the circumstances of their infrastructure. But the prerequisite for primary reconstruction is that you must debride it very well. And second is you must be sure that you'll be able to provide good soft tissue cover. For example, if you see in this patient, there's got a combined tissue loss. Skin and soft tissue is lost, extensors are lost, and there is a gap in the metacarpal. So this is a combined injury. So what we have done is we have taken iliac crest bone graft, and later on we have taken a palmaris longus tendon graft to bridge it. And once you do this critical steps, then this has to be covered, and we are covering it up with a custom designed radial forearm anti-flap. And once this forearm anti-flap comes, you find that the bone which graft that you have put, the bone graft has gone in for good union, and that's the clinical result that you get. So I think this is a reconstructed hand. So you're able to flex it well, this is the donor area, and is able to utilize his hands very well. So this is a primary reconstruction of a combined injury. I can give other examples. The most common things which is often missed is dorsal combined loss of the fingers, which happens in the missionaries. Here you find tissue loss, extensor tendon loss. If you see the X-ray, there is a loss of multiple phalangeal segments that's lost. But if you turn over the hand, you find the volar skin is totally all right, and it is sensate. So we should not allow this skin to be, these fingers to be shortened. So what we do, so we bridge them with the iliac crest bone graft for all the 3 fingers. And we are given a pedicle flap cover. I think that was the article which I quoted has said. We are given a pedicle flap cover, which we divided at 3 weeks, and the syndactyly is also separated at the same time. And that's the set of the results. We get it immediately. And that's the long-term result without any further surgical procedures. You will see that all the bone grafts have gone in for union, and he is able to do his activities, and we have saved these 3 fingers from amputation. So this can happen, this combined injury can happen the volar side too, almost the same type of picture given on the volar side. So here again, the same process, you put a bone graft, syndactylize the fingers, and a flap cover is given, and the flap is divided, and then the bone graft has gone in for union. So going proximally, I think now I showed you a couple of cases where we have done it primarily, but where we do in a stage reconstruction. This is a major combined injury. The key thing is debridement. See how well we are debrided, verse 1. Here we are not doing them in at the same setting, so we are giving them a flap. But then if you see now, we are giving the flap kind of in a designed way so that it fits in very well. We almost custom designed the flap. We use the KOS as spacers to keep the bones in position. And that's the flap that has been given. And 3 months later, we call them back, and then we have bridged these defects in the 2nd, 3rd, and the 4th metacarpals with iliac crest bone grafts. And they are gone in for union, secondary bone grafting, tenolysis, and then tendon reconstruction, tenolysis, and MCB joint capsulotomy. And there she is, she's able to use her hand constructively. This is a good way to come up from the time when you can consider the severity of injury which she had. So now we go to the next question, which very many people have, is when you have a combined injury, as what I have shown, and where is the components like skin, soft tissue, tendons, bones are all injured. can you make a flap which has got all things together? So which is called as composite flaps. So can you use a composite flap? So in our armamentarium, there are many flaps which are composite. You can take a fibula with skin that is taken, so you can combine both. There are certain things like lateral arm where you could use a nerve, you could use some bone, you could have skin, you can use that. So the question is, do you need to use composite flaps or individual component you should restore? In our experience, I have felt that it's always nice to go for individual component reconstruction, and each component must be restored to the best possible way. For example, in this patient is a gunshot injury. Here you find the exit and entrance wounds. On the dorsum, you find there's a bigger wound. And you've got a bone loss in the metacarpal. And you find that the tendons are lost for the index and the middle fingers you lost. Here you can choose a flap which gives you bone, which gives you soft tissues, and also you could put some fascia as the tendon in between. But what we have found is that it's very difficult because the geometry of the loss of the various components of the defect may not make it convenient to design such a flap. So what we do, we reconstruct each component to its best. So for example, what have we done in this is in this combined injury. So we have put an iliac crest bone graft. And we have taken a post-intraosseous flap, which will go this way. And we have taken some palmaris longus tendon grafts and then bridged the defects with the tendon grafts. We did that. And iliac crest bone graft, tendon graft, and flap cover that has been given. And here you see a result. See, you find the bone graft was taken, and you find the patient is able to make a full fist, and you find he is able to have no extensor lag. You can see the shadow. So he is able to extend, and that's the tendons where we are put in. So we have found that most of the times it's good to restore each component to its very well. So a question may be asked: is there anything that you would not do primarily? So I will hesitate to do primary nerve graftings because I need to be 100% sure that the soft tissue cover will not be a problem and there will be no infection. Only then and we should go for nerve grafts because nerve grafts are a very precious tissue, I think, which we can't afford to waste. And that's the only thing where I'll go with caution. But if I'm very sure of the soft tissue cover and I'm sure of the debridement, we can do even nerve grafting primarily. Now we'll end up with another case which will tell us about, which will tell us all the components that will go with the combined injury. So here you see a patient who has come after a road traffic accident. You find this fit and he has come a little late. As you could see the skin margins and the edema that has got. And we debride it well. So we've got the more margins that have been taken. The bone is all exposed. There's a good loss of the extensor tendons. The segmental loss of extensor tendons is present. And what we do is we decide on a stage reconstruction. We give it a groin flap. If you see this groin flap, you'll find that we have covered, you have a good amount of inset. Not only we give it up to that, we take it along so that the base is kept narrow, so the inset is kept very high. And after the groin flap is divided, I think that's the picture he's got. So that's the picture that he's got because he's got no extensors. They can flex, but then he can only flex from here to there. That's what I said. If you don't have extensors, even the flexors cannot act very well. And they, in fact, become weaker because the hand flexes only from here to here to here. So that's why. So now we take him up for extensor tendon reconstruction. The question is, when do you take them for extensor tendon reconstruction? The idea is that there's no question of 3 months or 6 months, no hard and fast rules. So we put in a place when there is very much, when it becomes soft and supple, we use fascial and tendon grafts and we bridge them up. And there you find, that means there you find after 6 months, you'll find full extension, full flexion. That's what he has got. Extension, flexion, and you find that this is the result that he gets. So in combined injuries, you can get good results. And it's important to reconstruct so that the uninjured components also act very well. So our capacity to reconstruct expands the indications for salvage. The most important take-home messages are you need to debride very well and the wound must heal without infection. You must provide a reliable soft tissue cover and we can obtain good outcomes with either primary or stage reconstruction. Thank you so much.
Thank you very much, Dr. Sabapathy. Thank you very much for the excellent talk. You have made the management of a complex injury look very simple. Chai?
Yes. So, hey, Raja, that was fantastic. And, having been at Raja's center, I've seen these in real time, see how well they do. But Raja, what I find perplexing sometimes is how do you schedule them? Because how do you plan your schedule? Doing them in a staged manner or doing them is all very well. How do you get around logistical issues? Do you have an algorithm that you follow?
Yeah, well, what we have done is, since the hospital is totally our hospital, so we are able to manage the whole system. So that's the thing. So all these major injuries are directly brought to the operating room. So where the surgeon, anesthetist, all of us, orthopedics, all of us see them together. So the time interval from arrival to the operating table is very short. And depending upon the schedules that we have, we think, okay, we'll go either a full thing or we do debridement and flap like that we decide. So in planning, what we decided was we need to have a more number of operating rooms and anesthesiologists available for the surgeon because I found that the output of a surgeon is directly related to the operating time that's available. That's a very simple statement. So once we understand that, I think everything falls into place.
The other thing I also noticed was maybe I got it wrong, but you tend to prefer a groin flap. Is that for expedience or versus a free flap with pre-placed hunter rods for extensor tendon reconstructions on the back of the hand?
Yeah, that's right. No, we found that we kept on refining the groin flap. And it is a system where a number of people do, and also there's a high volume. So we are trying to find a system which works very well in everybody's hands. And so what we find is for lower limbs, we do a lot of free flaps. For lower limbs, we do a lot of free flaps. For upper limb cover, we do this thing. But then we retain the microsurgical part of it to free functioning gracilis or to toe transfers. So that type of things where we do secondly for that, we reserve the microsurgical part in the upper limb. And we have found that absolutely we get equally good results. And by custom designing, we do it well and then we send them home after 5-6 days. So we are able to send them faster. We don't retain the flap with the groin flap flows at the hospital now. So we do them and then we send them home and then we get them back after 10 days for division. So cost.
Did we lose him?
I think we may have temporarily lost him.
Well,
Paul,
go ahead, Binu.
Yeah, Paul, would you comment on reconstruction? Do you do that as a stage procedure or would you do it in a single stage when one of these complex injuries?
So I try and do these all one stage. Yeah, the typical, and I will acutely tendon graft them through the flap, which the group, I think it was Louis Shekhar, Amit can correct me, described that. Yes. You can stick the grafts right through your flap. So I try and do it all at one stage. But I agree. I mean, coming back and doing your tendon rods later, your grafts later, you don't, at least I find you don't need to do rods for extensor tendons. But if you want to do your extensor tendons delayed, that's fine, but try and do it in one stage.
So, Binu, the other thing also is interesting is I didn't hear any discussion, or maybe I missed it. Do you see a role for using allograft tendons in any of these tendon reconstructions thus far? and if you have any experience.
Chai, Raja is back.
Oh, wonderful.
Okay, I think we can ask Raja the question. No?
Raja, unmute yourself, please.
We don't generally get to see allographs here. So that's what
I think I can comment on the allograft tendon. I've never used allograft tendons because allograft tendons give you sometimes unexpected immunological response, and you can get a cellular response which can lead to a lot of adhesions, etc. So I try to avoid allograft tendons for any flexor or extensor tendon reconstruction if possible. Allograft is only utilized for ligament reconstructions, and that's about it in my practice. So I don't use allograft for tendon reconstruction. I use it a lot for a lot of the toe tendons. In one case, I'd taken all 4 toe extensors from the foot to reconstruct the dorsum of the hand primarily. So that, I'll take the toe extensors very readily.
There's one question from the audience. How to repair extensors in case of extensive loss in zone 5? How to keep the tendons in center, and especially with the sagittal band kind of a reconstruction. Dr. Raja can take that.
Raja, unmute yourself, please. Unmute yourself, Raja.
If you have to re-extend the tendon distal to the MCP joint, that you can't do that. I think because it's very difficult, because they are all flat tendons, and usually I find that the best thing is for arthrodesis or for keeping them in a fixed position. Whereas the best way for that, proximal to the MCP joints, that you can always reconstruct. I think that's where we reconstruct. I think we can make the MCP joints move, and beyond that, it only be a sort of fixed length they have. So you cannot be reconstructing good extensor tendon, particularly big losses. We can't reconstruct distal to MCP joint. Whereas if we have a small defect like this, central slip and all that, and all you can reconstruct. But then large defects, multiple tendons, I think distal to MCP joint, we just go for making them getting them into a functional position.
So the proximal area, how will you do it, sir, if there are multiple tendons?
Yeah, what we do is I take a facial graft. So facial is available any length. So that again is very important, because if you are short of graft or short of length of graft, you are not fixing the distal side nicely. So what we said, if we have got enough length of graft, we go a Pallapati weave in both sides. I think all sides, we go Pallapati weave, very strong repairs. And the one thing which we have found is how do you put tension? How do you tension? So we find that if you make it too tense, but when you're trying to pick up an object, when you flex the wrist, fingers will extend off. If you have tension, I think that's the biggest problem. So what we need to do is that we do like this. We keep like this. We keep the MCP joint straight and keep the IP joints flexed, and then keep it in tight. So what will happen? In that way, if you do, then you will find that you are able to, the tension is very nice. You are able to, even when you flex it, you will be able to, they'll be able to continue flexing and picking the objects. So that's the way we do.
And one more question is, in delayed presentations with a combined injury and the finger is gone for stiffness, how do you approach this in terms of tenolysis, whether it will be extensor side first or a flexor side first? How is it?
See, because if you think that both are stiff, and you need to do the whole thing, because if you have the flexor stiff, flexor adherent, that means the extensor also cannot act now. So if you think both are stuck, I think all things have to be made, and proximal to the area, you need to open it and then pull it and see that it works. So that passively and then by pulling, you should be able to achieve the requested amount of movement. And you can never achieve more than what you achieve on the table. So you have to really go full way and then do it. And if there is any repair which is weak, that we strengthen it, so that immediately and the post-operative period after 48 hours, you really go full way. Full go, you have to go to get them moving as fast as possible.
So
So
it's
one
very
more.
important. It's very important what Roger said, that you have to do both at the same time, because if you don't do everything all at once, your finger's not going to work. Okay. So if you have situations where you have the stiff finger and you've done a PIP capsulectomy, extensor tenolysis, but you've ignored the flexor side and you've done it under a general anesthesia or an axillary block, when the patient comes back to the office, they will not be able to flex the finger, although you've done a very extensive extensor tenolysis and PIP capsulectomy. So then you are going back to the OR again. So if the patient is awake, you can ask the patient to flex the finger actively, and you'll be able to see that you will need to do the flexor side. So you can do small incision proximal to the A1 pulley, free up the tendon, and with the patient's force, when he's awake, he'll be able to break those small adhesions and get the flexion going. So do everything all at once.
Yes.
That's a great point.
Can I just add, Amit and Raja, we've been using intraoperatively the ultrasound machine to tell us. Once we've done one side, we use the ultrasound machine to check the opposite side and see whether that's stuck as well, and then make a decision. So even if the patient is probably under a block and not under WALANT, we could get an idea of using the ultrasound. We have the machine for the anesthesia. We've registered for the PCP NDT Act. So it's a wonderful a technique that we can use in the theater.
There's one more question from the audience to SRS sir. Will you consider primary reconstruction, that is bone, tendon, etc., even while using a distant flap in these kind of injuries?
Yeah, yes, we can. No? I think what really matters is debridement. If you think your debridement is good and your soft tissue cover is going to be good, you can go ahead.
Binu, one question that I have wondered about, and I'll throw it both to Anil and Amit and Raja.
Yes.
Where is the role for, or your opinion about Paneva-Holevich in these injuries? Where do you see?
So what is it?
The Paneva-Holevich.
What role?
Yeah. Paneva-Holevich, yeah, where you attach the flexor tendons together and then come back and do a secondary repair, right?
Yeah.
So so Paneva-Holevich described this tendon technique where you can primarily attach the FTS and FTP together, and once the tendon is healed, then you can come back and use the FTS as a graft to reconstruct the FTP. So this has been described, but I have not done this because what happens is that you end up doing the reconstruction or the repair of the distal part, and it's very hard to get the tension correct in that situation. So I have not used that for that particular reason, but it's an intriguing technique.
Yeah, I also never done this. Never been aware of it really.
So I've done it a few times and I've been underwhelmed by it. And just like Amit said, you do it in zone 3, you put the two tendons together, it looks nice, but becomes one gloppy mess by the time you come back. And I put a hunter rod in the flexor sheath to keep it open. And then I detach the FDS or the FDP proximally and flip it over. But it just doesn't seem to glide as smoothly as I would like. And I have to go back and do tenolysis, and the tension adjustment is not very easy. So it's a wonderful technique, but I haven't had great success with it.
I think the thickness of the tendon is also too much.
I think Paul wants to say something.
Go ahead, Paul.
I was just going to add to Chai. So I did this a couple of times early in my career because I saw it done once in my fellowship in France. And so I thought I'd try it, just like I watched my mentor, Fouché, did it. But I had the same experience as you, Chai. You're sewing tendons curved backwards and then expecting, and they form a big scar ball, and then you come back and you're trying to straighten it out. And we know how to fix tendons well now, so I don't do it anymore. I agree with you, Chai.
I mean, what is the advantage with this Paneva-Holevich technique, Chai? You think is it
so
because the tendon gets vascularized or something?
Well, yeah, you don't have to go looking for a graft. If you're going to
use it as a single stage, use the FDS as a graft.
Right.
we generally do.
So the thing is, if your flexor sheath is not very good shape, then you can always put the two tendons together and babysit the flexor sheath with a hunter rod and then come back. But, by the same token, you could just put a hunter rod and do a graft.
Also. Yeah. Okay, I think, thank you, Dr. Sabapathy. And I think we have, unfortunately, again, time restricts us. We have to move to the next speaker. Next speaker is Dr. Paul Binhammer from University of Toronto. He'll be talking to us about WALANT. Dr. Neeraj?
I'd like to thank Chai and the organizers for the opportunity to present applications and technique of WALANT at this Indo-US hand surgery conference. Thank you very much for the opportunity. I have no conflicts. WALANT means wide awake local anesthesia with no tourniquet. The local anesthesia is efficient, cheap, safe, and accessible. Epinephrine replaces the tourniquet. But maybe it's really maybe tourniquet. Epinephrine takes about 25 minutes to have its effect. Forearm tourniquet can be used right away, and patients can usually tolerate it for 20 minutes. You have to be cautious because there can be rebound hyperemia when the tourniquet is replaced or deflated, but it does serve as a good backup plan. The technique uses appropriate volume and concentration of lidocaine, 1% with 1 in 100,000 epinephrine. It's 7 milligrams per kilogram. When you inject, you have to manage pain, and you can do this by buffering the solution with 1 cc of bicarb for every 10 cc's of lidocaine. You need to make sure it's warm, use a fine gauge needle, inject perpendicular to the skin, inject slowly in advance. It takes time, both to provide the injection as well as the effect of the local and, as mentioned, the epinephrine effect. If you look up this article on tumescent local anesthesia for hand surgery, I want to warn you that the diagram is wrong. It shows the palmar side on the dorsum and the dorsum on the palmar side. The numbers are actually correct on the palmar side, which is the left side, where you can inject 1 cc at the DIP crease, 2 cc's at the PIP crease, and another 2 cc's at the MP crease. Dorsally, you inject over the middle and proximal phalanges using 2 cc's at each location. There is also a statement in this article that there is no one case of finger loss due to lidocaine with epinephrine. This is in fact incorrect. There has been loss of a finger. So you always need to have phentolamine available. I would also be cautious if I'm injecting for Raynaud's, peripheral vascular disease, sickle cell, or other conditions. The volume, as mentioned, is 7 milligrams per kilogram, and in a 60 kilogram person, this works out to be about 42 cc's, which means you have lots of local to inject. You don't also have to inject all at once. You can inject through a procedure, and you can also use timing strategies to inject more by waiting 30 minutes to increase the total volume. So you can do this for all sorts of things: carpal tunnel, trigger finger, all sorts of finger procedures, as well as flexor and extensor tendon repairs, simple tendon transfers, closed and open reduction of fractures. So why do we do this? Well, it's very cost saving and efficient. It's convenient. As well, you can invoke patient cooperation to have a dynamic assessment for things like tendon repairs, transfers, tenolysis, capsulectomy, when you may also be doing a tenolysis in addition. So I'm going to show you 4 examples of using it for dynamic assessment. So for flexor tendon repair, you can assess the strength of your repair. You can assess tendon gliding under pulleys. It may help you decrease your rupture rate, though this has never been shown. It's also very convenient, and you can involve the patient. This is a 67-year-old who 3 days ago sustained a glass laceration. In the clinic room, she has 5 cc's put in the palm, 2 cc's at the MP crease, and 1 cc at the IP crease. The nurse is asked to take the patient to the procedure room and organize. 30 minutes later, we start. We require a second incision to advance the FPL. A 6 FPL strand repair is performed, and the nerve is also repaired. No tourniquet, no cautery, both are available. We can then demonstrate to the patient the result of their surgery. We can also look and check the tendon for gapping, and we can then make a plan for post-operative management. What about tendon transfers? Well, you can also assess the tension, though it can be difficult because the patients lack proprioception, so they may not be able to exactly position their digit. It's very convenient, and again, you can involve the patient. So this is a 60-year-old who sustained an EPL rupture post-distal radius fracture. We've injected 2 cc's at the MP joint, 5 cc's at the other 2 incisions. We've done this in a procedure room. We use a tourniquet to start for expediency, identify the donor and recipient tendons, and transfer them over. Once we've passed the tendons and deflated the tourniquet, we can put in our sutures. We can adjust the tension intra-op to get the desired result. Both the surgeon and patient can have confidence to start post-op protected motion and achieve predicted results. For tenolysis, we can determine the outcome of surgery on the table. The patient can see the potential for outcome, as well as the patient can power to complete the tenolysis and minimize the amount of surgery. This is a 29-year-old, 9 months post left small finger proximal phalanx fracture, which was treated with closed reduction and 3 weeks of immobilization. 5 cc's has been injected into the palm. A tourniquet has been used.
Okay,
dissection has occurred at the A1 pulley.
For me. Squeeze down hard, hard, hard. Come on, harder, harder.
And tenolysis knives have been used under the A1 and A2 pulley until most adhesions are released. The tourniquet is deflated. Thumb is blocking the proximal phalanx flexion, protecting A1 pulley, and directs the force to work distally instead of flexing the MP joint. The patient is asked to flex, but can't do it completely. Another 2 cc's is then injected at the level of the proximal phalanx. The skin incision is then extended to window just distal to the A2 pulley. Further adhesions are released, and then repeat flexion is asked for from the patient. Listen for the adhesions breaking. You'll hear them in the video.
Bend your fingers down. Bend your fingers down. Hard, hard, hard. Hard, hard, hard. Do that. And straighten out. And straighten out. And bend down. And bend down again.
The patient can then see their result, and they know their achievable goal. For capsulectomies, passive range of motion has limitations. You can't tell whether it's joint contractures and or tendon adhesions or both. Once you've reestablished passive motion, you can then determine under local anesthesia whether there are further tendon adhesions that were not apparent, as well as other factors. This is a 40-year-old who 6 months ago sustained a drill press injury resulting in a small finger amputation and a dorsal wound over the ring finger. It was managed with dressing changes. Patient complains of loss of motion and weakness of the ring finger. The active and passive motion at the PIP joint is 55 degrees. 4 cc's is injected in the palm, 2 cc's over the dorsum of the hand. A forearm tourniquet is used to start. Extensor tenolysis and capsulotomy allow full PIP motion, being careful not to rupture the central slip. passive motion was 55 degrees and now it's to 100 degrees. However, the image on the left reveals active flexion is still limited. Tenolysis of the flexor tendons reveals quite minimal adhesions and the tendon glides easily with active and passive DIP motion. Still poor finger active flexion. Exploration of the small finger tendons reveals an intact FDP which is divided. Division of the FDP to the small results in significant improvement in ring finger flexion. This is called quadriga. Post-op therapy maintains the intra-op result. The gain is 60 degrees of PIP motion and the grip improves by 40%. So I hope I've shown you that WALANT requires adequate volume, adequate time, and allows you to especially perform dynamic intra-op assessment to improve your outcomes. Thank you.
Thank you, Dr. Binhammer. Thank you for the very clear presentation. I was a fellow in Halifax when Don Lalonde gave the injections to all the plastic surgeons in the meeting there with epinephrine. And I think this is one of the, the major things that have changed the practice of hand surgery in the last 2 decades. I just want the faculty to say who all routinely uses it and what are your situations where you use WALANT.
I have not personally used it. I have not personally used it, probably because our anesthesia department is so cohesive with us and they are always there. We have not used it personally. But when Don came to our hospital, he used it and showed it to us very nicely. And I think this technique has got a great place and it is a good technique. I think it's a very, very good technique.
I think during this pandemic, I have started using a lot because I immediately send them home. No post-op, nothing is much required. So during last 1.5 years, almost last 14 months, I am using a lot.
Dr. Gupta?
Yes.
I don't use the epinephrine, being old school and all that. So I use the forearm tourniquet quite extensively and have been using it for many years. One thing I don't like patient talking all the time and telling me their life stories while I'm operating. So I have this technique called SALANT, silently lying and not talking. So it's a modification of WALANT. So I will use local, but I'll use wrist blocks, I'll use local, but I'll use forearm tourniquet.
Chai?
So firstly, Dr. Lalonde, please forgive us. Secondly, no, I don't use it. I have never as yet felt the need for it, but I mean, after seeing Paul's fantastic outcomes, I think he's my new idol now. He was always my old idol, but now he's my new idol to try and emulate him. I seem to do what Amit does, where I use a lot of forearm tourniquet. And if I'm working in the digits, I will oftentimes use a wrist block or a finger block and try to get away with that. And at the very most, I will use an IV regional. And I use the technique for testing the flexor tendon excursion, which was taught to me by Mike Keith, where you use an Alice clamp and wrap it around the flexor tendons at the A1 pulley to check if you have the excursion or not. And the one point that I do emphasize to my residents is, which Paul pointed out and which is really, really critical when you do a flexor tenolysis, is to keep a digit on the A2 pulley as you're making the tendon move. Because if you don't, the force of making the tendon move will avulse your A2 pulley. So you've got to keep it compressed, reduce the moment arm, so it pulls in a straight line and not avulse the pulley off. And that, just in case people miss that, that's a very vital point.
I know there are 2 questions. Any situation, this to Dr. Paul, any situation where you had to use more than 50 ml of the solution? If so, what will be your combination? And how safe is it? That is one question. Second is, any experience with bupivacaine for longer action?
So I've probably used more than 50 cc's over a longer case where we've done something that's more than an hour. So yesterday, which sort of relates to the point I think that Shailesh or somebody raised about recently during the pandemic, it's can be more convenient than having to find OR time. So, for example, yesterday I had a patient who got their hand stuck in a dough making machine, and we have pretty big restrictions right now, and they would give me an OR but not any anesthetist, and it was a 2-hour case with a flexor, extensor, digital nerve, 2 articular fractures. So it took us a while. So we used more than the 40 cc's, but it was distributed out over a longer period of time. So you can do that. So it's very safe. And I think, though, as both Chai and Amit have highlighted, it's good not to be black and white about this. And that if you drink too much poison, you might actually make yourself sick. So don't be afraid to use a forearm tourniquet. It's not that there's anything really evil about the forearm tourniquet. So it's always good to have a backup plan. And I can't remember the other question.
Bupivacaine for longer action.
So there was a study recently that looked at whether it actually lidocaine plus epi actually made a difference compared to bupivacaine, and it's pretty minor. So there doesn't appear to be a big difference. And I'll just highlight one other thing. So Don's a great guy, but he developed, so WALANT has been around for a long time. But it really works for Don because of his particular setup where he had a series of rooms and he could go around and inject people and then operate in the rooms and do it sequentially. He had a nurse, so his situation really worked well for him. And so I think, as Raja pointed out, that it doesn't work for him because he's got so much access to anesthesia. So if you really have a lot of access to anesthetists and that's your setup, then maybe for a lot of situations it doesn't make sense to use WALANT. There's nothing evil about anesthesia. Maybe in some situations, certainly using WALANT helps. And certainly for me, for flexor tenolysis or capsulectomy tenolysis, I think it's really better than a GA. But I just don't think we should be rigid about, we should use all the tools we have.
Do you keep a syringe of phentolamine ready when you use the WALANT, Paul?
No.
No, in fact, I was just checking in Vellore whether there was something called phentolamine available, and so strangely enough, I found it is not available in our pharmacy.
Wow.
So I don't know about the others, whether they've checked or is it something they keep routinely?
Yeah, our anesthetists actually have it on their cart.
Okay.
One more question from the audience. Any experience of WALANT for flaps for fingertip amputations? Local flaps or a cross finger, any of these flaps?
I don't think I used it for the last cross finger flap I did because it was multiple flaps, but I've done it for homodigital flaps and I've done it for reverse homodigital flaps.
If you do that, Paul, does it kind of limit your ability to assess flap condition and perfusion or not?
I wouldn't inject my flap with it, but I'd use the same technique that you and Amit highlighted of using local, and I'd probably, I wouldn't use 1 in 100, I'd use 1 in 200,000, and I'd use a forearm tourniquet for part of the procedure. So I just modify the technique.
I see.
So is there any one single procedure you prefer to do a WALANT than under anesthesia?
Tenolysis capsulectomy.
One more question is the forearm tourniquet. What's the pressure and time? if it's being used?
200, you put it either forearm or you can put it at the wrist level. And usually I use it at 200 millimeters mercury.
And how long it is
You can
tolerated?
it's tolerated very well, especially if you go distally because there are no muscles, and you can put it on for an hour, hour and a half without any problems. And you can talk to the patient also at the same time.
And can the patients move the finger while the tourniquet is on?
Yes,
they can move the finger while the tourniquet is on, and also if once you take down the tourniquet, they can cooperate with you very well.
In fact,
and you don't need any sedation.
Yeah, in fact, before the days of WALANT, flexor tenolysis was done as defined by Strickland and Steichen using a wrist tourniquet. That's what we were trained on, I think, without dating ourselves. But
Dr. Warrior, do you use WALANT in Bombay?
Personally, I don't, because I work entirely in the private sector, and my anesthetists are a little wary about using it because they have their next appointment somewhere else and they want to run away. And I'd like them to be around till the finger pinks up again. But I think Pankaj uses it. Pankaj is around, I think. Pankaj, would you like to say something?
Hi, I use it quite often, ranging from PIP joint fracture dislocations, which I love to do under WALANT because most of these patients who come with a stiff PIP joint, once they see their fingers move very well while they're awake, the rehab becomes that much easier. And also for a lot of distal radius fractures now I use it. Just did one last week. I prefer it over general anesthesia because then I lose patient's cooperation in the immediate post-operative period about positioning, maintenance of elevation. Since I work as a standalone practitioner with no backup of resident doctors to look after my patients, I like to talk to the patient about all of the post-op positioning and immediate mobilizations immediately post-operatively. That's where I find it extremely useful.
just like Paul said, clearly a situation dictates a lot of stuff that you do, much like you described how Don Lalonde started off this. That's a very valid point, Paul.
Okay, I think, thank you very much, Dr. Binhammer. Thank you very much for this great talk. We'll move on to the next talk now. Dr. Shailesh Gupta will take us through fingertip injuries. Dr. Neeraj. Please, Dr. Shailesh Gupta is from Indore. He was with me while I was doing my fellowship in Louisville, and we've been great friends from then on. And, Dr. Neeraj?
Do you have access to his talk, or should I play it from here?
I have access.
Just in case OrthoTV is having some technical issues. There we go.
Oh, there we go. Okay.
Good evening, friends. Today I am going to talk about fingertip injury management with the local flaps. What is our aim of fingertip reconstruction? It should be having a normal looking appearance, it should be painless, and it should be having a normal sensation. If not, then what are the choices? It should be painless. Yes, it should be close to normal sensation if it is not having a normal sensation, and it should be close to normal looking. You must be aware of the fingertip anatomy. This is a just diagrammatic representation. You are all aware of that. This is epineccal nail fold. This is paraneccal. This is hyponeccal. This is globerous skin on the pulp area. Fingertip injury in which bones and tendons are not exposed are best managed with the moist dressing. This is one of the follow-up of just doing the treatment with the moist dressing, having a normal contour and normal sensation. But what happens? How do you manage if bones are exposed or tendons are exposed? This is one of the way to classify the fingertip injury, has been classically mentioned in the book. In type A, it is a transverse amputation with exposed bone. Type B is a dorsal oblique amputation, and type C is the volar oblique amputation. Based on this classification, various flaps are devised. But when the fingertip injury happens, it may not follow the classical pattern described in the books like this. So you have to have your basic knowledge application to manage the fingertip according to the circumstances. This is example of a girl who is 20-year-old having a fingertip amputation with a volar oblique defect with exposed bone, which used to perform thinner flap in this girl because she was too much worried about the cosmesis. So why we choose the thinner flap is because of color matching and in long term they usually get a good 2-point discrimination. This is a long-term follow-up, about 2-year follow-up of the same girl. It is a close to normal looking nail. A color matching is excellent. The contour is excellently formed. And this is one of the good choice for the fingertip reconstruction in a young adult. She is 45-year-old female, has a loss of pulp, presented to us about 7 days after injury, and she is having a fingertip laceration of the ring finger too. So what are the best option? I think the best option can be a cross finger flap in this lady. After the debridement, we plan for the cross finger flap. How do you do that? It's a diagrammatic representation. You raise the flap from the dorsum of the finger. You template the defect. You raise the flap above the paratendon. You cover the donor defect with the full thickness skin graft taken from the ipsilateral medial forearm and cover the defect, the injury defect with the flap. This was how it was done surgically. Covered the injury defect with a cross finger flap. The donor area was covered with the full thickness skin graft taken from the ipsilateral forearm, and tie over dressing was done. Look at the excellent result with a good flexion, minimal scar, but the color matching is not so good. A girl, 13-year-old girl, sustained a transfer amputation through the distal third of the nail. Parents were too much worried about the cosmesis. A VY flap was planned distal to the DIP joint crease. This is how the VY flap was marked, and it has been described in the name of Professor Atosai VY Plasty. And I am fortunate enough to work as his fellow during my fellowship period. The VY flap is developed and advanced. The advancement can be done up to 5 mm to 7 mm and close in a Y-shaped manner. And look at the follow-up. Follow-up at 2 years of time. She's having a not a close to normal, almost normal looking finger with a normal sensation and good contour of the fingertip. He is a 25-year-old laborer by occupation, work in the soap packing factory. He amputated the fingertip of the middle and a ring finger, having a complex laceration and a loss of the pulp and nilbed area. So we choose to do the homodigital oblique triangular flap in this patient. It is based on the one-sided neurovascular bundle along with the vena comitant. This is how we mark the flap, and the flap is based at the level of the PIP joint crease. The flap is raised along with the neurovascular bundle and vena comitant. This can be migrated easily 5 mm to 10 mm. The ring finger is already covered with this flap, and this middle finger is covered and the ring finger is ready to be sutured with this flap. Another example of complex fingertip amputation where the nail bed is intact with a partial loss of the sterile matrix with exposed bone. There is a U-shaped defect of the pulp area. By and large, radial ulnar part of the pulp and fingertip was intact. Based on the understanding the anatomy of the injury, we devised a lateral cutler flap on one side, which is based at the distal interphalangeal joint crease, and on one side a Sayek-Miller flap, which is modification of cutler's flap, has been raised. This is how it looks post-op before deflating the tourniquet, and this is after the deflating the tourniquet. Look at the follow-up at 4 years, a nicely maintained contour with a normal sensation. We get this type of injury very frequently. It's a complete amputation at the base of the lunula with some intact germinal matrix. Previously, what I used to do is as a composite tissue grafting, except the finger, we take out the bone along with the nail bed complex, fix it with the K-wire, and then cover with the flap. And nowadays, its modification, which is popularized as a graft reposition or over flap, is being done. What you do in that, you separate the bone, you separate the nail bed, and you fix individually first the bone, and then graft the nail bed and suture with the 60 chromic and covered with the nail plate to prevent the drying of the nail bed. And then the volar area in this case was covered with the thinner flap. Look at it from where we have started. This is around 9-month follow-up of the same patient, having a nicely reconstructed fingertip. When you have a thumb tip injury, you have to remember if the area of loss is distal 50% of the thumb tip, then you cover with the mobile flap. If the area of loss is more than 50% of the thumb tip, you cover with the cross finger flap. It's an example of bilateral thumb tip amputation with less than 50% area of the loss. This is one side, this is another side. This is covered with the Moberg advancement flap. Moberg advancement flap is based on the both neurovascular bundle, and it is raised above the tendon sheath. The marking of the incision is dorsal dark margin, and the volar relatively white margin. That will be the site of incision in this case. The IP joint is little fixed, and in some cases it is fixed with the K-wire in 10 to 15 degree of flexion, so that the flap can be sutured nicely. And in this particular case, because of bilateral nature of injury, I choose to prefer K-wire fixation of the DIP joint. And this is the follow-up the patient is having at 1 year of time. Thank you very much.
Thank you, Dr. Shailesh, for the nice presentation. Anil, any questions from your side?
Nothing yet, Binu.
Okay, this the GRF technique which you showed, how long do you have a follow-up, and do you think that there will be some resorption of bone after some time, and with the deformity of the nail?
I think the longest follow-up, documented follow-up I have is about 3-4 years. And the first case like this I did about in 2004. And so far he has not come back with any complaints. So I don't have the X-ray or a physical follow-up available with me. But so far he has not, he belongs to Indore, but he has not come so far with any complaints.
Shailesh,
yes.
When you do the Moberg advancement, and correct me if I'm wrong, the plastic surgeons in the group can perhaps tell me, it's actually the flap of Wesley Snow, correct? Described by Wesley Snow and then popularized by Moberg. Regardless, if you have to advance it so much that you need to pin it, do you see any utility in making a release incision at the level of the MP crease to allow your flap to slide distally?
So far, I have not done it because some form of flexion deformity of the thumb is not going at the IP joint is not going to have a functional outcome difference. Second thing, this case was particularly a bilateral thumb involvement. So having a bilateral, he will try to use somehow inadvertently during his day-to-day life for 3 weeks period of time. So that was a special case that I have made sure that I have to use the wire fixation for the IP joint.
All right. Okay.
I have a question for Paul.
The Moberg flap is not an advancement flap. It is a flap where the thumb actually has to flex to come and meet the flap. So the modifications where if you cut the skin and then advance it, that's a totally different flap. So this is the Moberg flap itself is not a true advancement flap.
Right.
I don't find leaving it 5 to 10 degree of flexion deformity of thumb is going to have any functional consequences. I am worried about any complication if it happens over here.
Yeah.
So
I have a question for Paul. Paul, you mentioned about retrograde flow homodigital island flap. Do you divide the nerve as well, or do you just divide the vessel and do a retrograde flow flap? Paul.
So when I've used this flap predominantly for dorsal nail planar type injuries where they've taken the dorsum off and there the digital nerve is intact and I leave the nerve intact.
Just take the vessel and rotate the skin?
Yeah.
Okay.
Is there a limit of how much advancement you are willing to accept, tolerate, or engage in when you're doing a VY advancement for a fingertip or for a Moberg? Where do you draw the line? Where is your line in the sand, Shailesh?
See, you mean to say how much advancement we can achieve with the VY?
How much are you willing to risk, or how much do you think you can achieve at the most?
5 to 7 millimeter max.
Yeah.
For the fingertip.
Yes.
For the thumb, yes, up to 50% of the pulp area. So basically, if you have a reasonable nail bed available, that's a good choice for the MOBA, because then cosmesis will be better. And then our three aims: sensation, penless, sensation, and close to normal looking. If I can, my first priority will be a penless, irrespective of the cosmesis, and then second will be a sensation.
Right, right. It'd be interesting to see what other faculty think.
I think if you are having a digital vessel along with it, then it's very good. If we can get a 1 centimeter in fingertips, we can get, and that's good. And in thumb also the same. And you raise like a Moberg flap, and then put a Y in, as David Elliott used to say. So once you put a V in that, as you said, no, it really goes even further, because the certain amount of limitation is because of skin, and then you really get about 0.75 meters to 1 centimeter you will get, and then you can close the defect primarily because the V is converted to Y. That again is possible. Yeah.
Is there anything you do special, Raja, to get that 1 centimeter in a VY? Because I struggle with that one.
Because when you do, it is all the fibrous part of it must get cut without cutting the other soft tissues. Sure. So I just pull it and then keep it in the tension, and then like jabs, you have the sharp knife and then press it on. It cuts only the fibrous tissue and not the other things. It doesn't cut. So then it's fine.
Okay.
There's one audience question to Dr. Gupta. Would you consider DMCA flap for thumb injuries if the neurovascular bundles from the thumb are injured, or the FDMA flap at all?
Yeah, the FDMA flap is good.
Yeah, go ahead.
There are two Dr. Gupta, so both can answer.
There are two Guptas, yeah.
I used to be mini-me when I was a fellow.
Shailesh, go ahead, and then we'll ask.
Can you repeat the question again?
Would you consider DMCA flap for thumb injuries if the neurovascular bundles from the thumb are injured?
Dorsal metacarpal.
Dorsal metacarpal. Yeah, it's a reasonably good choice.
Or the FDMA.
Yeah, FDMA is also a very good choice. First dorsal metacarpal.
Dr. Amit?
Yeah, I mean, obviously, if the neurovascular bundles are injured, you cannot do the Moberg flap. So you would have to resort to some other type of flap. So first dorsal metacarpal artery is a perfectly good flap for the thumb. Works very well.
Amit, do you have a limit of how much you'll harvest with the FDMA? And do you have a preference whether you use a flag flap or a kite flap? Does that make a difference?
No, it doesn't make a difference as long as you don't take out. You can take out the whole of the fascia, but don't dissect, don't skeletonize the tissues, because the first dorsal metacarpal artery and the veins are running in that area. You can take out all of the skin over the over the proximal phalanx in the index finger, and then go across to the. Pardon?
How far will you go distally? Will you go all the way up to the PIP
Oh,
or stop there?
up to the. You can go just proximal to the PIP, just like a cross finger flap type of in that level, and then you can come down and take that strip of fascia or you can take fascia and skin along with it as a flap, and then bring it over across. There is a modification, since you mentioned Penova Holevich. There is a modification which Penova Holevich, she used to take the radial digital artery of the index finger also. But no, I don't see anybody has used that. It's a double vascular transfer.
How good is the sensory innovation when you do the first dorsal metacarpal artery flap with branches of the superficial radial?
Not great, because it's what you're going to get is the dorsal sensation of your index finger, and there always is a feeling that you're touching the index finger. So it's the sensation regain is not great. That's why I prefer to use the Moberg or do toe pulp. You know, being in Louisville is great because we had fellows like Hong Chi Chen and Kim, and this guy Kim comes in from Korea and he says, "Oh, I've never done a local flap." I said, "What do you do?" I said, "Toe transfers." So I said, "How long does it take you?" He said, 1.5 hours. And I said, "Okay, show me." So he did it in 1.5 hours. Toe pulp transfer. So you can do that. Toe pulp is the best transfers for the thumb.
I always take the skin pedal along with the fascia, so that it becomes doubly sure and chances of more incorporation of brain is there.
I think, Shailesh, thank you very much. We should wind up this session now for the next speaker. That is, we have Sreekanth Chinchalkar from Ontario. We'll be talking on rehabilitation strategies for flexor tendon injuries and combined injuries. Sreekanth.
So is there a video? I mean, audio, I can't hear the audio though.
Yeah, the video is playing, but we can't hear the audio.
The audio is not coming.
Welcome to my session on rehabilitation strategies for Zone 2 flexor tendon injuries and in dorsal combined injuries. So Zone 2 is called as a no man's land because it presents us with many surgical and rehabilitative challenges due to complications. The common complications in Zone 2 include tendon adhesions or ruptures, PIP joint flexion contractures, secondary hyperextension or hyperflexion of the metacarpophalangeal joint, and quadriga effect. So these videos clearly demonstrate some of the complications that are likely to arise in Zone 2. So over the years, there are a number of authors who have introduced various protocols. Still to date, these are the most commonly used protocols. However, the other protocols are currently less popular. However, we use HULK protocol, and that is a combination of various protocols. HULK stands for Hand and Upper Limb Central, London, Ontario, Canada's protocol that I use. Sukuni back in 1990 identified that tenodesis motion of the wrist increases the differential tendon motion between flexor detorum superficialis and profundus in a fibroosseous sheath. And looking at zone 2 anatomy, we understand that orientation of superficialis in relation to profundus changes in zone 2. And therefore, for successful outcome, we must gain differential tendon gliding between flexor detorum superficialis and profundus in a fibroosseous sheath. So our management is for a 2-strand with epitendinous sutures or 4-strand repair or higher. Following tendon repair, we position the wrist in 0 to 30 degrees of extension, MCPs ranging from 45 to 60 degrees of flexion, PIPs joints in neutral depending on the neurovascular status. We begin with passive digital flexion and active extension as you see in the video on the right hand side. We encourage patients to perform active PIP and DIP joint flexion to 3-finger distance in first week, 2-finger distance in second week, 1-finger distance in third week, and then to distal palmar crease in the fourth week. At this time, we also encourage patients to perform wrist tenodesis motion. So these are the classical examples of the exercise program in first week, second week, third week, and the fourth week. Small finger management, however, is somewhat different. It's mainly because of the tendon diameter and considering the area per square inch of healing and the tensile strength. So between 4 to 6 weeks, we encourage patients to perform active digital flexion and extension and tendon gliding exercises. These are, of course, supervised program. We then progress to active PIP and DIP joint flexion with wrist in variable extension and flexion. So allowing digital extension with wrist in neutral in 30 degrees and 45 degrees of extension over time. The splint is discontinued around 6-week mark. Between 6 to 8 weeks, we encourage that patient perform the same exercise program as before, but at this stage, we'll initiate light activities of daily living and light resistive exercises. Between 8 and 12 weeks, we encourage patients to begin graduated strengthening in a supervised manner, and then we'll allow the patients to perform unrestricted use of the hand between 12 weeks or beyond. The results of our management are encouraging. Now let's look at the dorsal combined injuries. We know that the mallet finger injury is relatively very common or most common injury in the hand. It's often treated with the stack splint for a period of about 6 weeks. However, the stack splint causes swan neck deformity as one of the complications. So the deforming forces of the central band and medial band are right at the PIP joint. Subsequently, there's a gap scar formation at the terminal tendon distally, and there is a tendinous imbalance between the PIP and DIP joint. So in order to address the swan neck deformity tendency, we stabilize the DIP joint with the tape. We apply a tubinate for skin cover. We fabricate a cast, keeping the PIP joint in flex position, somewhere between 30 to 40 degrees, and DIP joint in slight hyperextension. The cast is replaced once a week. So this is the position that we use. By bringing the PIP joint in flexion and DIP joint in neutral, we allow the structures to be better approximated for better healing. So early phase management includes non-removable circumferential orthosis or a cast. DIP joint is kept in extension. We will encourage patients to perform passive range of motion of the DIP. As the DIP joint is held, they only perform PIP joint motion, and the cast is replaced with the splint after about 4 weeks. The intermediate phase of management includes finger-based dorsal orthosis. Same PIP and DIP joint position is used as before. Patients will perform daily range of motion exercises of the PIP joint only and not moving the DIP joint, and exercises are performed by the patient with 10 to 15 repetitions on a 2-hourly basis. The late phase management includes fabrication of DIP joint extension, which they use intermittently throughout the day. PIP and DIP joint exercises are performed by the patient. However, we still prevent these patients from doing any resisted flexion for at least 8 weeks period of time. However, the patients must use the nighttime finger-based splint with the same position as before in order to still control the balancing act between the PIP and DIP joint. The results are encouraging. Looking at the zone 3 and zone 4, it often produces boutonniere deformity. The most common type of an injury is avulsion or rupture of the central tendon or laceration of central tendon at the PIP or proximally at the proximal phalangeal level. So the clinical representation upon detachment of the central tendon shows that PIP joint flexes, whereas MCP and DIP joint hyperextends. So from the treatment point of view, we keep the MCP joint in flex position, PIP joint is held in full extension, leaving the DIP joint free for 2 weeks initially in a hand-based splint, and then PIP joint is maintained in full extension, DIP joint free with the finger-based splint, as you see right here. We encourage patients to perform DIP joint active flexion within the splint. So why we keep the MCP joint in slight flexion? Because the MCP joint flexion influences dorsal translation of the lateral band, which otherwise has a tendency to slip volar to the anatomical axis of rotation upon detachment of the central tendon. And why we leave the DIP joint free for moving is because it has various mechanical advantages. It helps with the dorsal translation of lateral bands. It keeps anatomical length of spiral oblique retinacular ligament. And third, it maintains transverse and triangular ligament relationship. The other form of management, if the tendon is transected, then they often require repair. Upon repair of the tendon, central tendon, patients are fitted with the yoke splint, as you see on the left-hand side video, and patients are encouraged to perform short arc of motion of the PIP joint ranging from 30 to 45 degrees in first week with 10 degree of increment on a weekly basis. The other alternative management is providing these patients with a template splint, keeping the PIP joint or allowing patients to perform 30 degrees of PIP joint flexion in first week and 10 degree increment on a weekly basis. And then patients also perform DIP joint blocking exercises so that the lateral bands continue to move. So here, of course, the patient is showing gradual increase in arc of motion, and ultimately the results are very encouraging. So the right-hand video that you see shows that patient has nearly 80 to 90% range of motion by the end of 8 weeks. Now looking at injuries, tendon repairs in zone 5 and zone 6, it's essential that upon repair of the tendon, the wrist be placed in 25 degrees of wrist extension. And patients are fitted with a yoke splint for 6 weeks period of time. So by placing the involved finger in hyperextension in relation to the adjacent digit, it minimizes tension at the repair site. And yet it allows motion of the MCP joint and PIP joint without producing any tension while the motion is performed. Obviously, it is important for us to monitor PIP joint flexion contracture and treat or minimize that from happening. Patients are allowed to perform resisted motion, preferably around 10-week mark and beyond. So this is the exercise routine that these patients perform following the tendon repair in zone 5 and zone 6. And of course, the results are very encouraging. So in conclusion, it's important for us to consider early management. Always begin with short arc of motion program, because we can very well say that the load displacement at the injured or repair site is directly proportional to the amount of motion performed at that joint. And therefore, early mobilization is a key to achieving excellent functional results. And besides that, it helps in minimizing or reducing complications. Thank you.
Shrikant, thank you for the excellent talk. Before we take on questions, I would like to share a short video which our therapist made on what we do for flexor tendon injury. I think Dr. Sudhir and Chai said we should, just share what we do in Vellore so that most people in India can, get a message from it. So I will just run this short video and then you can take your questions to
Sure,
also
yeah, thank you.
our presentation.
Perfect.
Yeah,
Thank
thanks.
you.
Just show that Sangeeta's presentation. Neeraj? Okay. If that's not count. Yes.
Greetings from Vellore. I am here to give you an Indian perspective of flexor tendon rehabilitation. The picture shown here is our hand therapy department in CMC Vellore. Mobilization protocol after flexor tendon surgery depends on the quality of repair. We use passive protocol for 2-strand repair and active passive protocol for 4-strand repair. We commonly use the modified Kleiner protocol, which is passive flexion and active extension protocol. The rubber bands from the outrigger are passed under the pulley to the fingers. Dorsal splint prevents stretching of repair site during the initial period. Immediately after surgery, in our center, surgeon apply a cast like one I have shown in the picture. To simplify rehabilitation, we have divided the protocol into 4 stages. On the second day of surgery, we apply a flexor traction. The patient is encouraged active extension of the fingers while the rubber bands flex the fingers passively. In stage 2, the patient is asked to flex the fingers actively under supervision during the therapy sessions while continue the traction at home. At 1.5 months, the outrigger traction is discarded. Patient is advised to do active finger flexion and extension till the dorsal block. At the end of 2 months, the dorsal blocking splint is discarded and patient is allowed to do light activities with WALANT splint. During therapy, other modalities like workstation, gel ball, and molding clay are also used. To minimize FDS, FDP adhesion, Bunnell's block splint can be used as shown in the picture. Progress is charted on a weekly basis by measuring total active motion and digitopalmar distance. At home, the patient is encouraged to do active exercise, car massage, and is not allowed to play sports and heavy activities. To summarize, this protocol prevents gapping at the repair site, minimizes the adhesion, and provides good to excellent results. Thank you.
Sreekanth, back to you.
Yes.
Do you use the Kleiner, modified Kleiner protocol, or do you use the Hulk regime as you said always, or is there a in your
yeah, I mean,
practice?
Sorry, yeah, I mean, you have to judge from a person whether the person is likely to be compliant or not, and by giving them education, we can understand that whether they're going to follow the instructions with the active motion program or Kleiner program. So there are some patients who would be better fit, who would better fit with the Kleiner regime as compared to the active motion program that I have shown. But we have gotten away from using the Kleiner program now in which majority of cases. We're not using Durand protocol whatsoever anymore. We used to use that back when. But there is quite a bit of discrepancy, especially if you look at the Durand as well as Kleiner. I presented this controversies in flexor tendon rehabilitation in one of the orthopedic conferences, where I pointed it out that yes, if the finger is pulled in flexion, and if you are allowing the person to perform active extension, this is depending on how the tendons were repaired and whether the patients are following the program exactly as you have given them. we noticed that patients had difficulty with extending their fingers because they had gone into developing flexion contraction. As Dr. Amit Gupta mentioned, that you have a 2 weeks window of time to gain PIP joint extension. And if you have not gained PIP joint extension, the quality of outcome is poor. Now, if you look at the excursion of the flexor tendon when you're using Duran protocol, for example, Duran mentioned that 3 to 5 millimeters of tendon excursion is enough in preventing firm adhesion formation between the tendons in a fibrous sheath. But if you look at the total amount of excursion of flexor deitorum profundus and superficialis, they may range up to maybe 22 to 23 millimeters. So how can you say that 2 to 3 millimeters or 2 to 5 or 3 to 5 millimeters excursion is enough in allowing maximum tendon excursion? So the recent studies have shown definitely that wrist disease is the key. The recent studies have shown that in order for us to maximize differential tendon motion between FDS and FDP, we have to perform the active range of motion program. And that's why we have gotten away from using Kleinert or we used to use Kleinert or Duran or combination of those two, which was advocated by Jimmy Chow, which turned out to be a Washington regime. So yes, in certain situations, we'll still use Kleinert depending on whether the patients have fractured and fractures are fixated. That's one. Two, secondly, if the patient, we judge if the patient is not going to be compliant, then we don't want these patients to have a high incidence of tendon rupture.
Sreekanth, I have a question.
Yes.
Between active and passive protocols, return to resisted activity is still 12 weeks, isn't it? When you do active, it prevents adhesions, it may be an advantage, but the final return to full resisted activity, is it earlier when you do active, or is it the same both in active and passive?
So if you're doing just a passive range of motion program, then their tensile strength is somewhat lesser as compared to when you are allowing patients to perform active range of motion. So the studies have shown that active motion program definitely enhances tenocytes deposition process, better remodeling, greater tensile strength. So you with the passive motion program, I will not start them on resisted program until 10 to 12 weeks, whereas I may start resisted motion program at about 8 weeks following active mobilization program. And especially that depends on what type of sutures the surgeons have used. So if they have used 2-strand and epitenar suture, that's relatively stronger as compared to 4-strand, that is even more stronger. And depending on whether it's a 6-strand repair technique, then you may alter the management based on the suturing techniques the surgeons have used.
So for a manual worker, would you ask them to get back to normal work at 8 weeks? No, it's still 12 weeks, is it?
Right.
So there is a lot of misunderstanding about the Kleinert protocol. Kleinert protocol historically has never been a passive only protocol. There is always an active component to this protocol. Okay, so even Dr. Kleinert, I've talked to him extensively, and there was always an active protocol. The other thing that I wanted to mention is that Jinbo Tang has clearly shown that when you do the active protocol, the final phase of completely flexing the DIP joint puts a tremendous stress on the flexor repair. So you should avoid the complete flexion and active flexion of the DIP joint in the initial phases, and only go up to that in the later phases of healing. Okay. So,
yes, I definitely agree with that, because we never ask patients to perform the whole entire composite flexion right down. Yeah, for quite some time. I mean, they're doing wrist tenodesis, means wrist flexion, finger extension. The tendons are gliding distally. When they bring the wrist in extension, maybe 50%, 60% arc of motion at PIP and DIP, and then gradually will increase arc of motion over.
Regress onto that. And the other thing that I noticed, Binu, especially in your presentation, that you're keeping the wrist in flexion. The more you keep the wrist in flexion, it increases the work of the tendon. So you should try and gradually be brave. Okay. Try and put it in slight extension.
Yeah,
okay.
we do. It does. Once a thermoplastic comes in, the wrist extension gets more and more.
Right. So I think that will help in the better flexion of the digits. Okay.
Can I suggest something? It's all these protocols have had pros and they've had cons. They've all been popular at some time and they've all been dissed at some other time. The bottom line is, I don't think one size fits all. And really, as a surgeon, you have to understand the personality, not only of your repair, but of the patient. So, you have to literally sometimes protect the patient from themselves and protect them from your repair from them. So whether it's a Duran, whether it's a Kleinert, whether it's early active, I think you have to make that judgment call. And sometimes I wonder if in a desire to make this outcome spectacular, we are willing to risk an early rupture. I personally am not, because rupture surgery is far more taxing. So I much rather accept a little bit of a PIP flexion contracture, but that's me. It all depends on our risk tolerance. So I don't know that we can, because for me, Duran-Hauser has worked remarkably well, but that doesn't mean it's the holy grail for me. I'll still go back to a Kleinert if I feel the need to, or early active.
I mean, the patient's history means a lot to us. For example, whenever we take a history, about how did they injure their hand. So they tell, oh, I was drunk the other day, and then, I got mad at somebody, and then I just used the bottle and then smashed the bottle. So it tells that the person definitely have an, a temperament or anger management issues. So those kind of patients definitely will not be very compliant with doing active range of motion program, because they are very much, sort of self-centered, maybe angry with the society, and maybe angry with you because you're telling them to do this, and they may not be following those strict precautions very well. Their likelihood of rupturing their tendons, and you don't want to have the tendon ruptures in our hands.
Thank you very much.
Question from the audience, Binu.
Okay. Last one. Yes.
Protocol for combined injuries. What's the thought?
So if you have say, for example, you have a mutilation or a replantation of the fingers, it's important that you consider the time frame in terms of management. For example, the person had surgery or replantation, that the flexors and extensor tendons are repaired. So based on the stages of wound healing, we know that after about 3 to 4 days, you will convert from inflammatory phase into fibroblastic phase. However, you have to respect the anastomosis of the arterial and venous repairs. You also have to take into consideration the nerve repairs. And after about, say, once your arterial flow is well established, your vascular status is well stable, then you can begin with a short arc of motion of the finger, doing this passively to begin with. And then in the second week, you can increase the arc of motion, passive flexion, active retention of that position rather than passive flexion, active hold. And then we'll gradually increase arc of motion over time. So it is important for us to consider better to move in a limited manner. And as I mentioned, that the amount of motion permissible is telling us the amount of tension placed at the repair site. So short arc of motion will not be detrimental in causing the tendon to rip or rupture. Of course, before we incorporate that program in our clinical practice, we definitely have to have an OR note in front of us and normally highlight all the details as to how the tendons have been repaired, how the vessels have been repaired, and then of course there'll be a direct communication between me and the surgeon to make sure that we are on the same page and we are managing these patients in accordance with the surgical procedure that have been performed for this individual.
Okay. Thank you, Sreekanth. I think I have to cut you short because we are completely overboard as far as time is concerned. And I thank Neeraj for allowing us to continue further. We have the case discussions coming up. I will request all the faculty to continue to be with us. And Chai?
Yes, keep going. Neeraj and Ashok, if you're around, please give us a heads up about what latitude we have and how much, and give us about a minute warning when you want us to end, please.
So the first case is by Dr. Anil Mathew, my colleague. And start, Anil. Thank you, Dr. Binu, and thank you, all of you faculty. We'll just run through the cases. So our first patient was a 33-year-old male, right-hand dominant, who used to work in a shoe factory and unfortunately put his hand in a foam cutting machine. So a foam cutting machine is something like that. It basically cuts large blocks of foam. It's got a sharp knife which cuts very thin layers of foam, which is used for lining of shoes, leather bags, automobiles, seats, and so on. So this is what the patient came to us with. The patient presented to us with this volar side soft tissue degloving injuries involving the index, middle, and ring fingers. He had no bony injuries. Essentially, he had these proximally based skin flaps. He had zone 2 flexor tendon injuries, both tendons involved in both the middle and the ring fingers. However, the fingertips remained vascular. So we took him to theater, debrided, and then put back the skin flaps because we were not sure whether how viable the skin flaps were on day 1. So this was a picture after 2 days. All 3 flaps began to show some signs of ischemia and began to become necrotic. So I leave it to the panel. I would like to know what next. So the tendons were repaired on day 1. We did a 4-strand repair for the FDPs of both fingers. FDS was repaired with a 2-strand repair for both the middle and the ring fingers, while there were no tendon injuries in the index finger. So this patient came to us last year, April 2020. So options.
So when you meet such cases, what I used to do is to have you do a repair, if you want to do the tendon repair or you want to do the nerve repair, do everything. And then I would straight away go in for a flap cover, because if you keep some hypovascular tissues beneath the repair or over a repair, that means always you end up losing problems. Or sometimes we keep this in doubtful times, but then 48 hours we see if it's doubtful. I think take off the whole area and line them with a flap. And because we like groin flaps, now we would give a just I showed you in one of my presentation. I think because multiple fingers, we do that. Because even if you try to give a free flap, they also become bulky. So this one you can really thin it and then put it on. We syntactize the finger and put in a groin flap for all the 3. So then sure we have got a well-vascularized tissue, and then later on we have syntactize the patient.
Yes, sir. So this is what the fingers look like when we took him back to theater on day 3. You'll notice that index finger has mostly got the fat over it. It's mostly an epidermal loss, while on the middle and the ring fingers, there is significant soft tissue loss. We can see the repaired tendons there. And what you'll also notice that is the neurovascular bundles are relatively intact, and so the fingertips are actually vascular. Now the problem is, because it was April 2020, and that is when India had the hard lockdown, this patient coming from 2 districts away, he requested that we do a 1-stage surgery, and that he did not want to come back immediately for recurrent surgeries. So this is what we did. So these were the options which we normally consider, like Dr. Sabapathy just said. We would choose a thin groin flap, a delta pectoral flap, maybe a pedicle paraumbilical perforator flap. These are easy options. The flap can be done quite quickly after debridement, and then separate the syndactyly and then go on with any further reconstructions if required. So we chose a combined flap here, a combined free flap, a combination of both medialis pedis flap, which has got this blood vessel which is coming from the medial plantar artery, the deep branch, while the superficial branch goes on to supply what we call as the instep flap or the medial plantar artery flap. And we put a split thickness skin graft for the index finger. So those are the skin markings you see here.
That's the tubercle of the navicular. This is the medial plantar artery or the instep flap, which is marked. And this is the medialis pedis flap, which is shown in this picture. So we actually made the division between the two flaps, the first incision between the two flaps. We've done a tarsal tunnel release. You'll see the end of the medial plantar artery there, going to form the deep branch and the superficial branch. The deep branch is going to supply this patch of skin here, while the superficial branch will go on to supply the sole of the foot. And we took a large pedicle. We dissected the posterior tibial artery up. And so you see two different flaps there. You'll notice that the medial plantar artery flap is quite bulky, like Dr. Sabapathy said. And that's another picture of the donor defect and the flap we did. This is what it looked like immediately after resurfacing. The medial plantar artery portion of it remained quite bulky, while the medialis pedis flap looked quite thin and nice. We did the anastomosis here. We brought the vessels around the thumb. We did the anastomosis here. We did an end to side to the radial artery and an end to end vein to the cephalic vein. So this is a few months down the line after rehab, which was mostly over the phone and through WhatsApp. You'll notice that the bulk of the medial plantar artery flap didn't allow the patient to actually flex the middle finger. While when finally the lockdowns went away and we could thin the flap, he was able to get a reasonable flexion. This is many months down the line. And that's the donor defect, which you'll notice there, and the range of motion he got at the end of close to 6 months of surgery.
Well, that's an excellent reconstruction. Functionally, got a good result. Yeah, congratulations. Very good job. You know, obviously the middle and the ring finger needed some sort of soft tissue coverage. And I think flap coverage of some sort, personally, I would have preferred to use a lateral arm flap with a syndactylized, possibly a fascial flap to cover that. I've used the posterior introsseous artery flap as a free flap for these conditions. But any sort of thin flap would be nice to cover that and syndactylize the fingers so that you can rehab them early. So that works well. The principle is good.
Paul, can we have your?
I agree with Amit, my leader.
So it's a hierarchy. So you're Chai's leader.
Chai then.
I'm just listening and learning.
Thank you very much, Anil. Shall we move on to the next case?
Yes.
Dr. Sreekanth, these are my colleagues.
Good evening. I thought I will do the third case, but anyway, I will do it now. We have a 30-year-old gentleman who has right-handed manual labor, who had a glass cut injury to the right little finger dorsum, treated outside with dressing and no proper treatment, came now with the inability to straighten his finger and deformity. And this is clinical picture. And on examination, there is no pain or tenderness. There is obviously the extensor lack. The PAP partial range of movement was full and Elson's test is positive, and this is the other image. On radiological examination, there is no bony injury or any arthritis. The adjacent joints are normal. So what will be the other options available? Any suggestions?
How old is the injury, Shrikant?
3 years.
3 years?
Yes.
Does he have any pain?
How much is the flexion deformity?
It's extensor lag is around 60 degree, 60 to 70 degree.
But you did say that
full,
passive motion is full.
The passive range is full.
Passive range is full?
Yes.
Okay. So, I mean, if you look at the proximal phalanx and middle phalanx, the middle phalanx seems to have subluxed somewhat in relation to your proximal phalanx.
Yes.
So, I mean, 3-year-old injury, I mean, sometimes you wonder that if the person had an inability to extend the PIP joint, it may not be an extensor lag, it could be possibly a flexion contraction.
Passive range is full.
Passive range is full, okay. What happens when you do a Bouvier test? If once you place the MCP joint in flexion, how far can he extend the PIP joint?
He can fully flex the DIP joint. And
no, but does he have full PIP joint flexion when you ask him to flex?
He can flex the DIP joint.
Okay, so when you block the MCP joint in flexion, how much extension does he have at the PIP joint?
The extension is no change.
No change, okay. So obviously the central slip is gone, 1. 2, the lateral bands have fallen volar to the anatomical axis of rotation at PIP joint.
Yes.
Your triangular ligament is attenuated. So I think, you can give a try, especially by holding the PIP joint in neutral, MCP flex, and allowing him to flex the DIP joint. My gut feeling is I don't think he is going to improve with the therapy. He definitely he's a surgical candidate.
Yes, I totally agree.
Can I ask you, what is his deficit? What can he not do and what's he complaining about? Because obviously he's lived with this for 3 years.
Yeah, he lived 3 years and he's going to get married soon. And
oh, yeah.
He needs the finger to be, obviously it's a little finger, right? And he needs to be done something which is, more presentable, and it is ceremony. And he.
So basically, it's a cosmetic thing rather than a functional deficit for him, right?
Yes. And he's a manual labor and his little finger, he's not worried about the movement, but that's the situation. So we thought about the reconstructive options, and obviously central slip is gone. So mobilization of the partial lateral band and reinsertion into the ring, or flip over tendon or tendon graft, Curtis technique, everything was in our armamentarium, even for exploration. And this is our idea of if there is a long deficit, we need a tendon graft, and obviously the palmaris longus would be our graft. And it will be, if you take whole, it will be too big. So we have a good technique of taking the half of the palmaris longus, take to the littlest technique where you take the tunnel through the base of the P2 and fix it to the extensor tendon and transistor joint. That's the technique we have been using it there. On exploration, this is the picture we saw, and you can see this whole central slip is being replaced by a gaff car, and surprisingly his lateral bands were intact. That was much impressed, and it was not fully subluxed, even though we thought like that in preoperatively. And this is what we did. We did a drill bit of the base of the P2, slightly dorsal to the long axis, and took the half PL, threaded through 8, and we made sure that when we pull it, the momentum of the PL will really cause us full action of the PIP joint, and we mobilized the lateral bands. We didn't have to much do the tenolysis, but just release that. So from the soft tissue, the lateral bands came to the dorsum, and this is what we did. We suture back the palmaris longus into the central tendon part of the extensor tendon, and we didn't do much about the lateral band. Transit with the K-wire, and we did rehabilitation the 6 weeks of finger cast, followed by removal of K-wire at 6 weeks. So early short leg movement rehabilitation, and further night spline for next 3 weeks. And at 3 months, this is the function. He has didn't get a full tension. He had a slight swan neck. That's because our tension may be slightly more than we thought, but the patient was not bothered of anything. He has almost good full flexion, and this is the function we got. Thank you.
That's in as much as I think that's a fantastic outcome, I would have some reservations about offering that complex a procedure for someone who's 3 years down the line, because I don't know that I can rely on that one case to say that I can replicate that outcome in each and every person. So I think it's fantastic, but I worry about it.
Yeah, this is, surprisingly, there was 2 patients on the same day when you operated. One Binu did and one I did, and both had good result. So,
we have this patient group who comes just before their wedding and they want all the hands to look normal.
Well,
So
that's,
they're not worried about all these.
like we discussed last time, the cultural differences are so important to understand, right?
yeah.
Shrikant, did he get married?
Yeah, of course. And he was very happy. He was a happy customer.
Then that's a good outcome.
I just have a small comment to make. In terms of the number of tendon surgeries I do, I perhaps do the least in this group. But there are 2 groups of patients whom I have consistently regretted operating. One are the boutonnieres who are moving very well, and the Malays who have no swan neck deformity. I have myself been consistently unhappy with the outcomes of these patients, and so have been my patients. I do not know what is the experience of the group.
I would tend to agree with that. I think if you look at Green's textbook, there are 100 ways of doing these boutonnieres. That means none of them work, or maybe all of them work. I don't know. So people are always looking for ways to fix boutonniere. A new technique comes out. So it is a challenge. Boutonniere is a challenge. Mallet, which is long-standing, is a challenge, and scaphoulonate ligament. 3 challenges left in hand surgery.
I have a little different take on that, Dr. Gupta. I mean, when you have a little finger flexion deformity, it does really affect their activities. Every time they try to put their hand in the pocket, the little finger gets stuck. Yeah. So I try to somehow, correct the deformity if at all possible.
Right.
How do you educate the patients about adverse outcome possibilities, Binu?
Very good question. In India, if you talk about adverse possibilities, most likely, they will not come. Do the case also. But at the same time, it does show like these cases comes out reasonably well. So I'm not too concerned that, I'm going to really make it too bad.
So I'm just curious, Binu, if you saw somebody with a 20 or 30 degree mallet, say a 30-degree mallet deformity, would you offer them surgery as opposed to somebody who's got a 45, 60-degree deformity? Do you go, no, this you should live with, as opposed to this I think I can make better than what you have?
Yeah, for mallet, I may not be that, surgically inclined, because many of these things, once you do a night splinting for some time, they do tend to correct a lot, even the ones that comes quite late. But for boutonniere, I think, if you give these reconstructive options, I think they can do well. So there I am a little more surgically inclined in boutonnieres.
I think if you, a PIP joint, especially of the small fingers, are very notorious. If you have a PIP joint flexion contracture or extensor lag, your your MCP joint always will ride in so much of hyperextension, creating more of a flexion deficit at the PIP joint. And on top of that, if you look at the small finger mechanics, it not only the metacarpal head has a greater dorsal curvature, but also has a medial curvature. So the finger has a tendency to not only go into hyperextension, but it also goes into abduction, and therefore it causes a torque, causing the small finger to rotate, giving you some scissoring. So I think small finger, as Dr. Amit Gupta said, that it's the most notorious finger in the hand, and it presents us with many challenges. However, small finger injuries are relatively quite common. We may see the proximal phalangeal fractures, we may see boutonniere deformity, we may see mallet finger, but I think they need to be treated somewhat differently, and especially we need to respect the small finger because the small finger has a tendency to produce up to 31% kilograms of 31% force when we are performing a grip. So if we lose functioning of the small finger, we have lost quite a bit of strength. And secondly, the small finger acts like a guide to your radial finger, so that you use that as a guide. You support the structure along the surface, and then you do a coordinated motion on the radial side. So therefore, small finger, I think we need to respect. And then even though it's a challenge, we still have to treat and make sure that we are bringing it to the normal alignment at the metacarpophalangeal joint, and subsequently we'll be able to recover the interphalangeal joint alignment as well.
Thank you for that comment, Sreekanth. The last case, Dr. Kiran.
Can't hear you.
Kiran, you have to unmute, Kiran. We can't hear you. Speak into the laptop directly. Not audible, not very audible.
He's not speaking only. Can you speak? Hello, 1, 2, 3.
Hello, 1, 2, 3.
Yeah, we can hear you.
Better.
Just say a
Slightly
little
louder.
louder. And hold the wire mic near your mouth.
Yeah.
Okay. This is a 36-year-old right-hand dominant lady security officer who presented to us with inability to bend her left ring finger for the past 1 month. She sustained a closed hyperextension injury while she was playing with her child. It was associated with pain, and she was initially managed elsewhere with some splinting. When she presented this was the attitude of the left ring. It was more extensive in the GAP joint. She was not able to actively flex the GAP joint, but she was able to flex the proximal left joint. The plain radiographs revealed that there were no bony apparitions. So we went on to do an ultrasound scan. It showed that the flexor sheath distal to the middle segment was empty, and the FDP tendon was avulsed, and it was lying at the head of the level of the proximal vertex. So we so how should we proceed with this?
So this is a month-old injury. So obviously this is a avulsion injury of the FTP, and it's stuck at the bifurca at the chiasma. So I would retrieve that and repair that, and then I would look at it. I would fix it, to the bone. I use the button technique and fix it very strongly to the distal phalanx, respecting all the pulleys. You may have to expand the A4 pulley, or you may have to bend the A4 pulley to a certain extent. And then I would consider whether I would do a tendon advancement, like a laviette, if it's too contracted. But at 1 month, it'd probably be okay.
Yes, so we decided to proceed with the reinsertion technique. So we had the surgical options available, including suture anchor, but in our setting, finances was a problem. Then we offered a pull-out using a button, but somehow on counseling, patient was mortified at the thought of having a button. So we then decided to go on and offer her the third option, which is the tilt method. In short, while exploring, we found that the ultrasound was fairly accurate, and the police had not collapsed. So we went on to do the tilt technique as prescribed by Sabapathy, which is a direct insertion onto the phalanx. Post-op, we followed the passive line-up protocol. So 4 weeks of ocular traction, followed by 4 weeks of active motion. And she was allowed return protein activities after 10 weeks. And this is 4 months. Ring finger is the injection. So tilt the transverse intraosseous screw technique as described by the can give results similar to all the other modalities, other options, and it does away with the problems like having a bottom upside.
Great. So that's interesting. And do you have any biomechanical data to show the superiority of the tilt over a Bunnell pullout or suture anchors? No.
There is some literature comparing the Bunnell's pullout to the tilt technique, and they have said that they're comparing similar results. In showing superiority.
What was the reason you chose the tilt technique over a pullout?
Patient then we explained that there'll be a button sticking out on her nail. She did not choose something modified by the idea having something outside.
This is a good example of shared decision making.
Yeah.
Binu? You're muted.
Unmute your mic, Binu. Binu, your mic is...
Right, I got it. Okay, so that concludes the case discussion and this session also. I would very much like to thank all the great faculty who contributed today for this. We have excellent talks and we have learned a lot, each one of us, and I'm sure the audience also would have really enjoyed this and learned a lot from these techniques, which has been described here. So over to you, Chai.
Thank you, Binu. Thanks to all the people who hung in there for 3 hours to learn with us, our sponsors, OrthoTV for giving us this extra time, and all the faculty. You've been phenomenal and done a great job with the discussion. I cannot forget my core team, Sudhir, Binu, Anil, and Pankaj, who have really helped put this all together. So thanks to all of you. Fantastic. Thank you so much. We'll see you again same time next Saturday. And in that case, it's going to be Sudhir Warrior, the Mumbai Indian, who's going to show us what we do with wrists. Right, Sudhir? Looks like he's gone for the day. Yeah. Anyway, thank you, everyone.
Thank you. And
bye-bye.
Good night.
Thanks.
Thanks, Raja. Bye.
Thanks, everybody. Thank you,
Binu, good to see you.
Thank you, Dr. Amit. Great to have see you again.
Sam,
Thank you.
Bye, Raja.
Thank you.
All I see you every day.
Yeah. Bye, Sreekanth.
Bye.
Bye, Raja. Bye, Chai.
Bye, man.
Have a great weekend.
You too. Good night.
Anil, bye.
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 You, Anil, Shailesh, bye.
Bye.
Pankaj.
Bye.
Bye.
Tiger.
Pankaj, is it your painting on the background?
Yeah, the sketch is mine, yes.
Oh.
Yeah, that's beautiful.
Okay. All right. Thank you.
Okay. Bye.
Bye.